Good morning. My name is Elizabeth McClaney, and I'm the Director of Interprofessional and Academic Education at Sunnybrook Health Sciences Center. One of the most important questions I think humans can ask ourselves is, what are we learning? When complexity is involved, when circumstances are changing, and when we need to find new and innovative solutions, we need to ask, what are we learning together across professions and roles, institutions and organizations, and along the continuum of care? These times are truly unprecedented, and we are honored to have a diverse group of presenters and teams here with us today to share what they are learning. Welcome to our 11th annual and first ever virtual Interprofessional Collaboration Showcase. This is also the third year the event has been co-hosted as a partnership between Sunnybrook and the Center for Interprofessional Education. The showcase celebrates excellence in team-based learning, collaborative care, interprofessional research and quality improvement, and leadership across our healthcare system. The IPC Showcase brings together like-minded colleagues who understand the importance of teams. Each year we pick a theme for the conference. Originally, we had selected igniting collaboration along the continuum to recognize the evolution of our system and the advent of Ontario health teams. And then our world changed along the way, and our planning committee found that the idea of partnership has become even more powerful as the unique circumstances of COVID-19 have brought forward the best in teams in terms of being nimble, adaptive, and flexible. In terms of welcoming new members and collaborating on the go, even leaving their home organizations or units and assisting in different settings. As teams have welcomed new members and changed their structures, concepts like psychological safety have risen to the forefront. Partnerships within and across the system have become essential. In some ways, we can say that this was the year that silos stopped mattering, or at least that working successfully across silos was the only way for healthcare to do the best we can for those we serve. In addition to our usual focus on core competencies for teams, competencies like role clarity and interprofessional communication, I would like to emphasize that today you will hear stories from teams and team members who have been courageous, who have been creative, and who have strived to optimize team performance in new ways. We are truly appreciative that our presenters have taken the time to help us answer the collective question of what are we learning. I hope that you will enjoy today's showcase and that it will provide you with a sense of connectedness and community when it comes to interprofessional learning.
All right, thank you, Elizabeth. Hi, everybody. I'm Sabrina Bartlett. I am the project manager at the Center for Interprofessional Education and one of the co-chairs for the IPC Showcase. Before we get started today, we do want to acknowledge our great planning committee, as this would not at all be possible without you and your dedication to the showcase. We've been so lucky to work with such fantastic individuals who span across Tasman and community partners, and who brought their expertise and insights spanning across many different areas. This is a very unique time for everyone, and we were thrilled to hear that the committee still wanted to offer the conference this year, but in a virtual format. This was a first for us, and while it's been a different experience to plan and execute this virtually, it's been a great opportunity to learn and collaborate together as we work to reinvent this year's showcase. I wanted to just share a picture here. This is what some of our meetings have looked like. We're all very happy, and so despite it not being in person, we did have a very fantastic time planning this collaboration showcase. It's also important to acknowledge how far this year's conference span. We're delighted and happy to say that we have over 285 attendees from various organizations across Toronto and the GTA, and some a little further. Thank you to everybody attending, and we hope that the speakers you hear from today spark excitement, ignite ideas, and inspire us all to enhance collaborative healthcare. During today's conference, you'll hear from several key partners, as well as leaders from across Tasman. We're excited to present a panel discussion, hear various team stories, as well as hear from a patient, a student, and a staff member. During a time like these, it's also important to remind ourselves to practice wellness. So we've also included a wellness moment for everybody to enjoy. On that note, I think we should dive in. I'm very excited and pleased to turn it over to our panel guests, which will further introduce themselves and provide some context about some of the new roles they may have taken on during this current context. We'll start with Maria, Then we'll move on to Tracy, and last but not least, Nazanin. If you do have any questions during the panel discussion, please enter them in either Twitter or Formstack, and we'll be moderating those for you. Thank you, and I hope you enjoyed. Over to you, Maria.
Good morning. So just by way of introduction, I'm currently, I guess for the last 10 or 11 years now, the director of the University of Toronto Centre for Interprofessional Education, as well as senior director for the School of Continuing Education at the University Health Network in Michener. And actually I'll be drawing on some of my learnings from teaching for the last decade and being co-director of the U of T UHN Collaborative Change Leadership Program. But in the last 3 months, I've taken on a new assignment. And so I've been the project lead and chair for the Provincial Education Task Force for COVID that has been curating, developing, and deploying educational resources to upskill and orient in an online way those who are being redeployed during COVID. So it's been just an incredible experience over the last 13 weeks. And I'll pause there and turn it over to Tracy for introductions.
Hi, so I am Tracy Dasgupta. I'm the director for interprofessional practice here at Sunnybrook Health Sciences Center. And similar to Maria, I've had the opportunity over the number of years in this role to really spend time focusing on teamwork and collaboration and what that actually means as we bring teams together. And as the world changed, as Elizabeth shared, it really was an opportunity where I was assigned to work with developing alternate care models, working with team members to create new roles, to integrate those new roles into the acute care setting and critical care, working collaboratively and building off of the work that Maria was leading. So therefore, already seeing a partnership across the system, and I will have the opportunity to share some of those learnings working with our team members and our leaders across the organization and system. And I'm going to pass it on to Nazanin.
Thank you. Good morning, everyone. I'm Nazanin Kududus, Director of Technology Enabled Education at Unity Health Toronto. And Technology Enabled Education includes simulation programs, e-learning and LMS, health information and knowledge mobilization, as well as telemedicine and virtual education. And I've been in this role for a short while, and before that I've been managing the simulation program, and prior to that I've been working with different clinical areas in the clinical nurse educator roles and variety of clinical bedside or education roles across Unity Health Toronto, St. Michael's Hospital, and in different countries actually over the last 20 years. So excited to be here and share my experience through the last few months and the role we've been taking and how we've come together in the technology-enabled education to support the needs and for the last interesting few months that we've been living in.
Wonderful. Thank you so much. So our first question today, and perhaps we can start with actually whoever wants to start, but we're curious, what was it like to bring together teams that may have never worked together? What enabled them to accomplish great things, and what was that secret sauce?
Maybe I'll jump in. And perhaps just by way of context, to tell you a little bit about the team, because it is about 50 people. And I will say, as the project lead, I haven't necessarily met all 50, even though we're all pretty much working online. So there are people who have project expertise. There are folks who are digital experts, clinicians and clinical leaders, scientists, senior leaders across the system, educational specialists, and funders. And when I thought about what it was like, I came up with 3 words. Because this team has accomplished an inordinate amount in about 10 weeks. So when I think about what's been accomplished on what was the critical care learning platform, now called the COVID care learning platform, the team launched 12 different professional tiles to support upskilling and orientation. So those are profession-based. 4 content tiles related to infection control, bioethics, team-based care, and wellness and resilience, just to pick up on Elizabeth's earlier comments. There are 6,800 users on the site, so the reach has been incredible. All 14 local health integration networks and 50 different professions or roles who've accessed the site. We've been able to get external funding, a fair bit actually, to support the digital infrastructure, and also our first external grant to actually do some research on the site. So the three words that came to mind for me in terms of what was it like to bring the team together, the first one was inspiring. Just watching people step in and lead in ways that they may not have had the opportunity to do before based on their strengths, because they wanted to find a way to contribute to the pandemic was just incredible. So really an attitude of saying yes, even when we were, not just stretched a little bit, but stretched a lot in terms of what we had done before or what we knew how to do. The second one was humbling. I have to say, in my 30 years in healthcare, this was the most rapid collaboration I've ever experienced in health professions education, and I'll pick up on that theme a little bit later. But I had a moment when my dad was critically ill in Thunder Bay, and I see there are colleagues from Thunder Bay Regional on the conference today. I had an opportunity I played a kind of the point person role in my family, connecting with the healthcare team, and I was having a conversation with the intensivist one day. And it would have been, had we not had that one moment, completely blind to me that he and his team members and colleagues at Thunder Bay Regional were using the criticalcarelearning.ca resources. And so just to kind of know that in some way, shape, or form that might be helping my dad was just incredibly humbling. And the last one was daunting. I mean, we were given 10 days by the Toronto Region Steering Committee for COVID to deploy an education strategy, which then went provincial after about 14 days. So we started with the region and then went across Ontario. And I just thought, I had moments where I thought, how are we going to do this? And so daunting, but just letting go and trusting that we had the right people on the team to really carry this work forward. So that's what it was like. And maybe I'll pass on to whoever's next.
So maybe I'll pick up from here. And Marie, I'm going to say those are excellent words. And I would say, and. So as you were saying those, I'm like, yes, yes. And I would say, and on top of that, the realization and recognition that we are all in this together. I think what maybe I'll do is just give a little bit of context in terms of exactly what was happening. I'm going to say within our organization and beyond as it relates to the work that was happening from the education learning platform. When we talk about the world changing, from an organization or health system perspective, it actually meant that we were preparing for something that we didn't know. And that was the daunting part. And we didn't know how long we were going to have. And that was even more daunting. And we were watching the world around us, knowing that the world was changing. And we were anticipating and preparing for potentially that being our experience. And so inspiring, yes, in seeing the number of healthcare providers rising up and saying, how can we help? How can we be there? Knowing that we were going to be needing tools and structures to guide that, and we were going to need those very, very quickly. We needed to pull people together. And there really, really was this true sense of community and connectedness that we were in this together. So we knew roles were going to be changing because some of the care that we were providing stopped. And that meant some of the work that people were doing wasn't present there anymore. We were anticipating we were going to have more needs in critical care, and we were anticipating that we were going to have healthcare providers not being able to come to work because they themselves would be ill. And so we were anticipating the significant pressure. And so the models that we developed, and we developed those collaboratively and with our teams, our frontline, with our leaders, really preparing for how would we create the system where we each relied and depended on each other. We created alternate models in acute care, knowing that if we had to release team members to work in critical care, that they would be available. We needed tools and learning to support that, to move acute care nurses into critical care so that they could work alongside critical care nurses that were experienced. So bringing acute care nurses without experience in critical care, training them with a little bit of education and information and readiness to get them able to work with critical care nurses in the critical care setting. And the whole system rotated and the whole system relied. on each other. We then started to see help being needed from our community partners from long-term care settings. And we needed to be able to provide staff to be able to work there. And so it was only through our alternate care models in both acute care and critical care that we were then able to release staff. And that enabled us to work collaboratively. And so when I think of what's the thing that really stands out, there was this daunting, there was this courageous feeling that people were stepping into roles, not knowing, trusting that there was going to be a way that things were going to emerge and we were going to be able to work together, that the tools would be there to connect us, to keep the care safe, despite the fact that we may or may not have as many healthcare providers or team members as we would normally have, and that our roles were all going to change and we were going to need to be flexible and nimble, all of those words you've just shared, to be able to move in and embrace roles that we weren't really certain of how they were going to unfold. And so there, as you step back, there's this feeling of awe, of inspiration, because you kind of say, look at what we were able to achieve, look at the outcomes, look at how we made it happen. And the stories that are emerging are amazing. The stories that are emerging are actually pulling together all of the themes that we've talked about in terms of interprofessional collaboration. And it totally makes you feel humbled, for lack of a better word, to see what can be accomplished when we all have a common goal, a common need, and a human experience that connects us all. So amazing would be the word I would be left with. Nazanin?
Well, you both said it all. I absolutely agree with everything you said. It has been a humbling experience. What's been happening over the last few months, and I'm nodding and saying yes to everything that you both said and adding to that. But as Maria, you mentioned, as we were bringing these teams and these individuals together, I think the attitude of saying yes, and everybody came in with that mindset that we are here with that shared mentality, that we're here to provide care for our patients and we're going to do whatever needed to be done. And it was heartwarming and humbling and beautiful to see that. To put it into context, I'm going to highlight bringing teams together as responding to impact that the COVID had on restrictions to visitors, policies and cancellations of non-essential appointments and ambulatory services and modifications to our inpatient workflow and physical distancing. We had to really switch into virtual platform and provide care and leverage virtual care solutions in order to be able to provide care and support for our patients. And I mean, virtual care is not a new topic, and we've been leveraging that platform for the last few years, and all of us have been, I guess, trying to move that to the next level. And probably same as Unity Health, a lot of our institutions, we've had plans, 1 year and 3 year and 5 years plans ahead of us, that how to ramp up our virtual care and where we go from here. But reality, with this external force that pushed us to implement that 5-year plan over 5 days, and we had to bring teams together that we've never worked with each other before. We don't even know some of those team members, from the clinicians and practitioners from different disciplines, to educator and education teams and telemedicine and virtual care, to our IT and technology folks that they had to come to support these teams. Also teams from legal, ethical, privacy teams that they had to join us. We had to work with Ministry of Health on the billing and financing side, working with Ontario Telemedicine Network, OTN, on the platforms that they had. What do they have, what they don't have, what we need to build on. Working with third-party industries such as Zoom to modify the options that they have, how we can make it safe for our patients and for patient care. And not only just building those guides and tools and processes, but also parallel to that, we had to think about our practitioners and our different disciplines within our practitioners, that we had to build capacity, how to utilize this platform. It's not just about building the platform, but how we can educate people and build capacity to safely use the virtual platform to provide care for our patients. and communicate with each other and communicate with our patients and families. And so we had to partner with our academic partners, Center for Faculty Development, and then I'm just bringing more and more systems and groups and teams into this mix. And it wasn't only communication between the clinicians and providing virtual care, but also patients. They needed to be able to communicate and connect to their families and their loved ones and their support system. So our patient experience and community engagement had to work with IT to provide virtual family visits and provide the services and support for our patients. And we had to do all of that overnight, like in 3 days. And it wasn't easy because all of us, these different teams, not only disciplines, but different sectors, we train differently, we think differently, we process things differently. But that common goal that we had to do this for our patient, and we were all in it with the attitude of we're going to make it happen, that pushed us forward. But the secret sauce, as you mentioned, it was that safe environment between all of us that we knew we were doing this task, that this task with this magnitude in this time frame was never done before. So we were all going in with the mindset that there are a lot of unknown there, and it's okay not to know, and it's okay to make mistakes, and it's okay and it's safe to ask questions and to share those mistakes and be in that safe environment with each other, and trust that we're all doing our best to help each other to move forward. And as Tracy mentioned, that trusting that each other and the system that was there to support us, but also the fact that we all embrace the fact that it's okay not to know, and that psychological safety that was created because of that helped us communicate better and move forward. And yes, there were times that we were taking 2 steps forward and 1 step backward, and that was okay because it was fast-paced and we had to learn together and grow together. And that process was it was amazing. That brought us, even though a lot of these people in different groups, we still haven't met each other, maybe some of us in person, but we established that. And over the course of 3 months, we had 1,200 patient virtual visits, or we had the clinical visits for our patients. We had 70,000 virtual clinic visits, which is 4,500% increase from our baseline in March. And all of that happened in 3 months. And that's the trust, and that's the safe environment that we, as teams, we were able to create. And I'm proud of that, and it was humbling to see that.
You know, as you both speak, what strikes me thinking about all the work we've done across our community around interprofessional education and team-based care over the last 10 years is everything we're saying about leading large system-wide projects is the same as what we say in terms of what enables amazing clinical teams. So there's that parallel. And I just wanted to pick up also on the comment you made about maintaining our curiosity and asking questions. You both talked about that. And, you know, some of the questions we kept asking ourselves in our projects to keep us grounded and true to the principles we committed to at the beginning of this work was, you know, what does collaboration, really good collaboration, look like when you're moving fast? How are we learning and adapting, Tracy, to pick up on some of your comments? How do we continue to be in service of what's needed for the system as a whole? And what do we need to let go of to be able to move forward? And one of the things I think we needed to let go of was in healthcare and in healthcare education, we aim for great and perfection. And given the speed at which we were moving, I think one of the things we had to be okay with was being great, doing great work, having great quality education, but not waiting for perfect, and just saying, this is awesome. Okay, how do we learn and how do we take it to the next level? But not waiting for perfection, I think, was really critical as a secret sauce ingredient.
I want to pick up on that, and it's interesting, like how your mind continues to think and grow as you're actually sharing some of those words, and it's like, yes, that's what I'm thinking and feeling. And I think the couple of the pieces is, the first was, this wasn't easy, and there's a feeling that comes with that, where people start to, you know, you're moving so fast, the trusting of the process, you're trusting your colleagues, you're feeling uneasy at the same time, and I think what we tried to do from a psychological safety perspective, and it's interesting because as we were moving in, before the world changed, we had started to talk a lot more about psychological safety within teams, and what does that mean to feel safe to speak up, and all of a sudden it had real applicability, and people were using the words, and we were talking more about how important it was for people to feel safe to speak up, and to feel that you weren't 100% perfect, or things didn't have to be perfect, or you were questioning if you had the skills and tools to actually take things to the next level, and you had your partners and team members around you. And that was being felt at all layers and levels. So people providing the care, people not providing the care, but working remotely from home, but feeling just as vested in the work and care that was being provided. Leaders who were creating the environments and supporting the environments. And I know I had my own moment at that weekend, just as we were getting ready. We had actually just started to support the long-term care facility, and this great unknown of what that environment was. And I remember being in the park walking my dog, and I actually sent a picture to my sister, but I was smiling, but inside I'm like, I'm not smiling, right? And so this sense of, you know, do I really have the skills? And I think that's where the wellness and the resilience comes out, because how do we as individuals and teams continue to grow and be more resilient and emerge in this environment that is extremely complex and unknown and uncertain? And how do you adapt as individuals? How do you grow into those skills, and how do those strengths all bring your teams together? And just, I think I'm just tying together some of those other concepts, but the adaptability, and there's a secret sauce in allowing and enabling that to grow, in leaders creating and supporting that environment that enables that to grow, but also feeling that it's okay not to be everything, and to be free and vulnerable enough to be able to talk to that. And there's a secret sauce in that too.
Wonderful, thank you. Nazanin or Maria, did you want to say something else before we move to the next question?
Just a small but maybe important thing to add around psychological safety and vulnerability, Tracy, and that is, at least for me, knowing that I have, and maybe I'm very blessed to have, a number of trusted colleagues that in my own moments where I was, you know, not having a very energetic day, I was tired, I was in the judger pit and maybe not in that full learning stance or curious stance that I talked about, having a few people that you can really let your guard down was an important part for maintaining my own wellness and resilience, to just be a little bit raw. And so, you know, when we talk about vulnerability, it's absolutely, Tracy, what you said. How do you create that within a team? But it's also, how do we create that in ourselves to stay strong and resilient? And so I wouldn't want to lose that individual component as well, because it wasn't easy all the time.
That's true, Maria, and I'm 100% agreeing with you. And that vulnerability, as you mentioned, and letting those guards down and sharing those moments, but also acknowledging as leaders and as team members that we were together, embracing that vulnerability and sharing it with each other was important, because we were all in it together, and it was important for us to see that there are other leaders and that other team members in this task that they are as vulnerable as me, and it was actually making it feel more okay, and that we're all embracing it, and that will make us the resiliency that will come out of that, and how we can actually thrive because of that, and the support that we can provide for each other, even just by sharing that with each other, was very, very important during the process.
And I think that, you know, just as you're saying, like, how do you ensure that that's able to happen within teams? And so one is that environment that is created, and the other is that you've got almost some systematic ways to ensure there's a space for that to happen.
Mm.
So some of the team process tools, and I know that was some of the work that went into the learning platform, but you know, what's the role of huddles? And when you bring teams together and you go around the room and everybody says what their name is and they introduce who they are and what they bring to today, what strengths they have, or even what things they're worried about or not certain about, and feeling free to put that into an open space within the team. And the team tools and the processes enable that to happen. Some of the pauses in a staff meeting or a debrief where you're actually checking in and saying, how are you doing? How is everybody doing now? And so creating that environment that you can actually speak up, or that if there is an idea or a perception that's brought forward, that because we knew we were working at such a pace, that you've got the ability to shift it and to reshape it. And everybody feels that they have the power to have ideas and to create that change that's going to make things better for tomorrow, because today was a tough day perhaps, or today was a great day and we want more days like that. But the team processes really support helping some of those things to really live on a daily basis.
Yeah. Maybe a couple of really small examples of team process outside of the team process tools that Tracy was talking about that we brought into our initiative. We have a task force of about 30 people, and we have an hour in the early stages of the project, an hour a week. That's not a lot of time. And so we didn't have the luxury of full introductions. And so as a small project team, we thought about how are we going to get people to really kind of get to know each other and be able to create that space where people can contribute in a safe, vulnerable way. So we did things like instituted a roll call at the beginning of the meeting where I would call out everybody's name and role on the project really quickly to kind of orient new members and reinforce what people were there for. We had a membership list that kept getting updated that people could refer to during meetings if they wish, so they would know who people were. And then we intentionally invited the brilliant Catherine Parker from Holland, Bloorview, as a developmental evaluation expert to sit on our provincial task force. And we embedded a developmental evaluation conversation into every meeting so that there was an opportunity to sometimes spend 4 minutes, sometimes spend 10 minutes, 15 minutes in a meeting saying, what are we learning and how do we need to adapt? So those were some concrete ways that were quick and dirty, but super effective that anyone could bring into any type of meeting structure.
Wonderful. Thank you so much for sharing. That's fantastic. And the three of you have kind of already addressed some of this, but we want to explore a little bit more about the Canadian Interprofessional Health, Health Collaborative Competencies. Is there one that jumps out as supporting collaboration at the system level for you? If so, what did that competency look like in action? What team behaviors were enacted? And what factors contributed to psychological safety? Maria?
I went first last time.
Tracy or Nazanin?
Okay, well, I'll speak to role clarity. So role clarity, it was interesting because we were working with so many different teams in different settings. It was like the thread that kept coming up. Although we were planning very fast and implementing very quickly and thinking about role clarity, it was also the one area where we had the most, I'm going to say, significant gap, that when things weren't going well, it was from a lack of role clarity. And there were a number of complexities to this because we had created, obviously, as I had shared, new roles. So we had created what we thought were these alternate care provider roles. We had tried to define what we thought the functions were, what were the things that people would be doing within these roles, and provided the education to do the capacity building. At the same time, the world was continuing to change and we had staff that were away and we were piloting working in alternate models. So bringing new people into new roles with a little bit of training and working in a setting where some of the staff were not there. So they were already under duress, and role clarity kept coming up is that we didn't understand what people's roles were. And it was throughout, right? So both in acute care, it was in long-term care we saw it, and we saw it in the critical care setting. And so on a daily basis, we were talking about how do we actually strive to improve that. And so some of the tools were very concrete tools, like a passport. So through the education, there was a passport that was used to say, here's the things that I've actually learned. And very simple things like making the passport available to all of the team members helped everyone to understand what was in the role of the alternate care provider. We had some people lightly share, I wish I could put something on my chest that actually said, here's the things that I can do, here's the things that are within my role, to make it absolutely explicit. We struggled with, additionally with role clarity in terms of, I'm going to call it almost professional association. And so it's in my real role, I'm an X, I'm a something, but in the alternate care provider role, I'm not. And so from a role clarity perspective, and maybe that's a little bit different, but people were challenged with not feeling that they were aligned with their actual professional role. And so we ended up with some challenges of, people really feeling almost like a lack of value, for not being valued for their knowledge, their professional knowledge, their professional education, because they were working within this different scope and role. So I would say that this was the one thing that came up broadly, and it really interesting, and this is where you sort of look at how the whole system's connected. I was coming in to work one day, and we had created a team coordinator team that was checking in with all of the alternate care providers every day in terms of how are things going, what do we need to shift, what do we need to reshape. And in order to create that team, we actually drew on other healthcare providers from other settings. And so we had someone working with us, from our, different settings. And so where those individuals had even left, I had this person come to me and say, our team is struggling because we're actually trying to figure out what our roles are, because we've actually lost some of our team members. And so I think from a competency, from a behavior, what are the things that are important? What are the things that we can do? But really recognizing that it looks and feels a little bit different everywhere, but it is 100% relative to every single part of the system, and something that we really need to continue to focus on so that we can create as much clarity. And it's almost like as much clarity as you choose or try to create, there's still more that you can do, and that feedback will come from the people within the roles. I think I'll pause there and see if anyone else wants to add.
Well, Tracy, you pretty much said everything I was about to say, because I was going to highlight role clarification as, all the competencies really apply, but that was the first one that jumped out when I was thinking about it. And as you mentioned, one of the reasons also was a lot of us, we were wearing different hats, which were kind of not the usual hats that we normally wear in our roles and in our practices. So not only we had to constantly go back to learn about each individual's and each team's roles and responsibilities, we had to remind ourselves with our own roles and responsibilities. And we were also, a lot of us, we were wearing different hats because we were involved with multiple projects, and our roles were very different in each one of these projects. And sometimes it's hard to switch hats, and you have to constantly remind yourself that within the context of this team and this project and this deliverables that we're working on, what is my roles and responsibilities, and what are the things that I need to do, and what are the things that actually I need to take a step back because it's not my role, even though it is my role in the other team that I'm working with. So in that fast-paced and really less than different from our usual and normal roles, that was highlighted even more for me. And also understanding, and during this, for example, to provide virtual care, virtual education, we had to work with teams that some of those teams or team members and roles, we had no idea. We never worked with them before, but we didn't even know what that title or that role means. So it was a lot of openly communicating and explaining it for each other to make sure that we have a great understanding that what the roles are, and then we can recognize and respect it and integrate with each other in a meaningful way. Which brings me back to another competence, takes me to another competency, which is the communication, interprofessional communication. which is such an important factor when you're working in such a fast pace and in different roles, not only interprofessional, interdepartmental, intersectional communication, that we had to keep it live and keep it active and keep it real during this phase in order to make sure that we maintain that shared mental model, we maintain that understanding, common understanding that what we're doing, what is the goal, what's the deliverable, and where we're at. And as we were all, again, had a lot of side meetings and side conversations and different roles and responsibilities, it was easy also to get lost a little bit in what everybody knows, and I'm assuming they know that, or I don't know that. So we had to really create within each one of these teams and these projects that somewhere on a daily basis or weekly basis, really that check-in moment, that for the first 15 minutes, we go back and review everything that happened in the last 24 hours, because I might assume you all know what happened, but you might not know, and vice versa, and make sure that we bring it back to that central place and share it with each other, to not to lose that that common understanding, that not only what our goal is at the end of this, what's our goal is for the next hour, next day, next 3 days. I mean, the time spans are very short during this phase, so we really had to be on top of that communication, and it was highlighted to me more than ever, the importance of the interprofessional, interdepartmental, intersectoral communication.
So picking up on a few of your comments, Naz, for you, like all the competencies showed up in the project for sure. The one I picked was collaborative leadership. Although as I hear both of you talk, I'm also reminded that all the competencies actually have some overlap, of course. They're not completely distinct, but for me, the one that really showed up was collaborative leadership in this initiative. And it actually was an incredible experience. I mentioned earlier that I've been teaching in and co-leading the Collaborative Change Leadership Program for over a decade now. And we introduce a lot of case studies, but for me, this was like the Uber collaborative change leadership case studies. And so I've actually gone back to think about some of the concepts we teach in the course and how they showed up in this project. And one of them was the concept of sensing and emergence. So we had a plan. The original plan was launch 10 tiles within 10 days, because that's what mandate we were given for 6 professions and 4 content areas. But we really paid attention to questions like what's emerging, what's happening in our environment that we need to pay attention to really make sure that our work has the most significant value and quality. And so while the initial focus was on critical care, we soon realized, because we worked closely with Tracy and team around the model of care, or the alternate models of care, people were going to be redeployed from acute care. And so what were the acute care resources, educational resources that were going to be needed as people then needed to be redeployed into acute care? And then within about 2 weeks, what emerged was clearly there's been a crisis in long-term care for longer than this pandemic. But we were asked by the Ministry of Health if there was a chance we could adapt the learning strategy and the materials to long-term care. And so again, within 14 days, what started as regional went provincial, went from critical care to long-term care. So who could lead that? Who could we partner with? And so reaching out to great colleagues at Baycrest in the education team and the Ontario Centres for Learning, Research and Innovation in Long-Term Care to be our stream leads for the long-term care piece. And then continuing to pay attention to what was happening, what was emerging, things like PPE starting to be breached because of responsive behaviors with some of our residents in long-term care. So really reinforcing some of the infection prevention and control resources. And then as we move into this next phase and continuing to pay attention to what's needed, our students who aren't on clinical placements. So making these resources available to them as they re-enter practice. Needs around pediatric care. So you'll next see a pediatric tile on the site in the next few weeks. Naz talked about essential visitors and families and caregivers as essential partners in care. So we'll be launching a compassionate care tile. And then all of the work around virtual care and a lot of requests to pool the resources potentially provincially on this site around virtual care. So sensing and paying attention to what's emerging was critical. I think the other one, because you've talked so beautifully, both of you, about things like complexity. No one person can see the whole system. You've got to distribute leadership. We've talked about asking appreciative, generative questions. But the other one I would highlight is strengths. We spend so much time as human beings and in healthcare, and I reflect that in my own training as a physiotherapist 3 decades ago, focusing on problems and problem solving. And gosh, we could have spent lots of time thinking about like, who's done this kind of work before and what are the barriers and how do we overcome the barriers? But really thinking about who at an individual level has what strengths that we need to bring to this team. What are our system strengths that we can carry forward to get this work done? So really focusing on what we have, what's working well, and how do we build on that? And I would say the last one is that humility of not knowing. We had a moment, actually I'll say 2 more things. We had a moment where we realized there was a significant need around environmental services, and no one on the team had that sort of expertise. So having kind of the boldness to reach out and cold call people you didn't know. So we reached out to the Ontario Housekeeping Healthcare Association, the OAHA, didn't even realize they existed, to say, you've got great resources around environmental services, would you contribute them to this project? And they do it at a revenue. And so negotiating and being bold to say, this is what's needed, would you help, was another key part of collaborative leadership. And the last thing I would say is, sometimes when you use the word collaborative leadership, for some people it means like a nice way of leading. And I have to say, this project, in the spirit of creating psychological safety, collaborative leadership is also about making difficult decisions. And we did have a moment where I was working with an individual who I would just say did not share the values and principles that we had committed to as a team, as a task force. And so it was finding a way to say, partnering with this entity is actually not in service of the work, and making those tough decisions. So I think we can't forget that collaborative leadership is sometimes making some tough choices in the spirit of protecting the psychological safety of the group so they can get their work done. So those are some things that popped to mind for me around the competencies.
Thanks so much, both of you. I just want to share one additional reflection. And, it's interesting when, I'm saying that you spend time thinking about concepts and frameworks and how do these really apply to practice, and how do the things we learn along the way shape you to be ready. And so I'm just going to make a couple of comments. So Maria was talking about the Collaborative Change Leadership Program, and I actually had the opportunity to be in the first cohort of that. And so, that's actually where I learned about the complexity and the emergence. And, it's interesting when you think about your own learning and what you learn along the way and how it becomes the framework of your worldview and how you lead. And so very much when you say it was, we moved into, this was really the essence of what the world was becoming. It really did help to frame this living with uncertainty. And so thinking about how you interacted, thinking what the communication was, like those curiosity questions, like where you're actually engaging and sensing and, what is today like? And so I think that's the first thing. And then as we think of ourselves as healthcare professionals, as individuals, as team members, what are the things that we continue to learn and grow all along, our journey of, whatever our life journey is, and how does that relate? And I think, it ties into this whole human experience that because this environment was not just about our work, our professional work, it was also about our life work, that our lives were being impacted, that there were childcare issues. There were so many other impacts larger than people's professional roles that played a role in. And so I think that takes it back to that whole complex environment, because it was not just the healthcare system, it was the world that was creating the complexity. I think the next thing that I just want to sort of just put out there is that whole interface between interprofessional education and interprofessional practice. And we've always talked about what happens on the the coal face, or you know, what happens at that intersection. And you know, there's been lots of, you know, discussion, and you know, what does it actually look like, and you know, how does the education apply to the practice, how does the practice inform the education? And I think what this actually did is it brought it all together, because we were all reliant on each other. You know, Maria and I are connecting in terms of what are the things we think the teams are going to be needing. Those were the things that we're actually developing. The system continues to change. You're sensing how it's changing, and then you see the learning and the education. So it was everything moving in tandem together for what it needed to be, moment by moment. And it was, I think, that in this rapid pace of change, it actually accomplished so much more in terms of bringing that intersection closer and closer together than we've ever seen before, that all of a sudden it became just the way it is, as opposed to a framework or a concept, or how do we actually apply it. It just became it is. And that, I think, really stood out for me.
Wonderful. Thank you so much. And we do have an audience question here, and it kind of talks about what you had mentioned around, you know, being a unique time. There might have been a lot of unknowns, and ensuring you take care of yourself. So the question from the audience here was, were you afraid or scared? And what kept you going and on track?
Yes,
Nazanin,
Yeah.
you wanna go first?
Go Naz.
well, yes, the honest answer is yes. There were a lot of unknowns, and there were a lot of uncertainty. And as I think Tracy, you mentioned, and Maria, you mentioned it also, we always tend to want to be perfectionists and make sure that we know the answers before making a decision. In healthcare, we take the change management, we take our time with our change management to fill all the gaps and know all the answers, and then take it to the next level. And all of that, we had to push them away and think differently and think fast, and be comfortable with not being perfect and not knowing and moving forward. And it was scary, because it was different from what I guess most of us are used to. And trusting your teams and trusting the system and trusting the leadership was the important part, and keeping that communication line open to make sure that I was, for myself, sharing those fears and of unknowns and those uncertainties, and hearing other people's responses and comments and support. And to your point, Maria, about building on the strength of individuals and teams during that phase was really important, because that uncertainty and that fear, you could feel, I was feeling a lot better when I was knowing and learning about the strengths of my counterparts in this whole process, and how we could build on those strengths and rely on those strengths moving forward together. And that was a part that I think supported me and our team to move forward.
Yeah. It's interesting. First of all, thank you for the question. Talk about keeping us honest and ensuring that we're showing you our vulnerability. Fear is an interesting thing. You know, it can have a double-edged sword. When I think about the question, what immediately came to mind for me was, absolutely there was fear, but on the personal level, none of us knew anything about the full impact of this virus. And so initially the fear for me was about, what does this mean for my family? What does this mean for my dad, who's sitting in an ICU 1,600 kilometers away from me? And so actually the fear in that way was a generative thing. It was a positive thing, because it fueled my energy. I don't know where I got the energy for the first 8 weeks. I won't tell you how many hours people put into this project. So the fear, actually, if I could let go of it, and I did ask myself in moments, what do I need right now to let go of this fear? It actually was fuel to keep me energized, because I think many people on the project would say, although we weren't directly caring for patients and clients and residents, it was a way to contribute meaningfully. So that was really important. I think to the point of how did I stay well, resilient, take care of myself in the face of all that, I would say rituals. I wish I could say that I maintained my exercise regime. I'm getting a lot better at that. But there were certain things that I absolutely maintained, and it was my children who kept me honest. So dinner with my family every night, but not committed to it has to be at 6 o'clock. You know, sometimes it was 8 o'clock, sometimes it was a 10-minute dinner, but having that ritual where our family came together to connect for dinner. And, you know, even we're four at home, even if it was two of us for breakfast or a few of us for lunch, having coffee in the morning with my husband. And actually my husband's made coffee 90% of the time. So having that. And what I said earlier, trusted colleagues to decompress with, as well as creating that psychological safety within the team. So thanks again for the question.
Thank you both for sharing. I'll just add that, you know, at the time that COVID was starting, my daughter became ill and had ended up in hospital. And so you're going through a significant change at work, and you're also experiencing a health challenge in the home. And, you know, everything was fine, and she was at home, and she spent a lot of time on the couch listening to my remote teleconferences, and, you know, saying, yes, I think that would be a good idea. You know, just like she was in and out, but she could hear the conversations that were going on. And so I think, you know, the fear, yes, for the unknown for your family. And my own mom, who lives with dementia, who, you know, was most of the time in our house, and we moved her to her own home and tried to set up all of the, you know, supports around her so that she could be safe in her own setting. And then feeling obviously some responsibility for what was going to be unfolding in terms of partnerships and collaboration throughout the hospital. And so I think that the biggest thing that I relied on was the trust of the teams, is that, you know, you would stand back and you would see the teams coming together and leading, and that collaborative leadership, and, you know, the ideas that were emerging and the pace of change and how things were just happening and falling into place. And they obviously don't just fall into place. They happen because there's amazing people that are driving them forward. And so I can't even begin to say how grateful I am for, you know, the teams that actually, you know, drove all of that forward. I think there was a fear, and I mentioned it a little bit about when I was, you know, in the park and taking that smiling picture of myself. Like, I think that weekend was probably the worst weekend I had, where, and I'm not sure if it was fear or feeling uncertain or not feeling enough, or, you know, were we going to be ready, and sort of all of those things coming together at the same time. And, you know, knowing you've got a circle of, you know, amazing colleagues around you, knowing that things are moving in the right direction, but still always not knowing what lies just beyond. In some way, I felt like there was this window closing the whole time. And, you know, was the window still open a little bit? Did we still have a little bit of time? And, you know, each day would go by and it would be like, okay, it's like, okay, it looks like we still got a little bit more time, just enough for us to continue to put those pieces in place. And I can tell you that the first day that COVID graph came out, that, you know, really showed that it had started to flatten, I think I don't know if I smiled or got these shivers, but there was something that like physically happened within my body, which is like, okay, maybe this isn't going to be, you know, what we were hoping that it would not be. And so yeah, like that's there, and everybody, you know, experiences it in different ways. And I think that's what we really tried to do, is create the spaces for people to share those different, you know, those different feelings and those different examples of how they were continuing to feel well. I will say, like Maria, I did not follow my exercise routine. I love running, and I was terrible, and my dog gained weight and I gained weight. And so, you know, and I think that was a sign, like, okay, things are not quite on, and we're just starting to get that, you know, back on track now. But we really did try to think across the organization from a wellness perspective. You know, how did we ensure that, you know, all of our team members had a space to talk about their fears, and whether it was the fears of their children not, you know, doing their lessons, you know, in the best possible way, because now parents were becoming teachers, or, you know, elderly family members in homes, or, you know, as we had said, like roles changing. Just, there were so many fears, all experienced differently, and people just needed a space to either be able to share it, or to know that it was okay to feel uncertain, or to know that there were other resources that they could tag into if they needed to. And we really hoped that people would do that.
Great. Thank you so much to our amazing panel. I'll just ask in our last couple of minutes, is there any key things you want to make sure you said? Otherwise, we'll move into the next portion.
I just like to say thank you for the opportunity and the space for us to think together. You know, I think we're a panel, we're three perspectives, and really hoping that the thoughts or the ideas are resonating in some way. As I said, everybody has their own and their own experience. We're all connected, we're all in this together, and you know, just really grateful to be part of this discussion today.
Yeah. I guess I would say I started with sharing some keywords that reflected what it was like to bring this team together. So maybe I'll end with one word that I'm feeling after listening to Tracy and to Naz and thinking about this whole experience, and that's hopeful. I am absolutely amazed, again, having worked in healthcare for 30 years, sometimes how slow change can happen. And in the matter of hours, days, and weeks, silos that have never been busted have been busted within our own organizations and across organizations, and picking up on Tracy's comments, between education and practice. And I'm hopeful that that will continue post-COVID, that we've learned a lot about how to collaborate across our systems, and that we'll carry that forward with us into other change initiatives and into our day-to-day work. So thanks for having us today.
Thank you.
Thank
I'm
you.
echoing what Maria and Stacey said, and Tracy said, and thank you for having us. Thank you, both of you, for sharing your experiences, and I'm really hoping that we can take what we learned forward with us and build a more collaborative healthcare education environment moving forward.
Yeah.
Thank you.
Amazing. Thank you so much to our amazing panelists. So much for us to think about. The rest of our presenters will be introducing themselves and leading their own transitions, so we keep everything moving on time. So just a huge big thank you.
Hi there. Oh, I guess I'm on now. So thank you. I'm Dana Whittam. I'm the clinical leader manager of the COVID Assessment Center at St. Mike's. I'm going to try and share my screen because I do have some slides, and in particular some photos that I wanted to share today when we're talking about the team perspective in the COVID Center. So I'm going to do that now and hope that you can all see that. Everybody see that okay? I'm hoping so. Okay, so I thank you to the group that have asked me to speak today. It is really an honor to talk about this particular team. Never have I had the opportunity to see a team from the very, very beginning. So this is an opportunity, a very unique opportunity, where we can flow through all of the stages of a team development and see collaboration at its best. So I'm happy to share all of that here with you today. This is where it started. So if we go back 15 weeks ago, two physicians at St. Mike's, an emergency room physician and a family doctor, who they'd never met before, got together in one of their backyards and drew out the COVID Assessment Center on a scrap piece of paper. They needed it to do two things. Obviously meet its goal, which is testing people, but do so in a safe way that was safe for staff and safe for patients. Sounds easy, but this all happened in a span of 5 days. So in that span of 5 days, it took more than 100 people to put this place together. So the COVID Assessment Center was designed and sourced and built in 5 days. Throughout that 5 days, as you can imagine, there were many, many people involved. And then there was the practical side of things. Now we have a built structure and we have a plan and a flow. We found the money to do such things and so on. And then we needed staff. So staff were redeployed from all areas of the hospital. They came primarily from ambulatory clinics, so places like ophthalmology, or kidney transplant, or things that weren't running at that time, endoscopy. And so all of these different staff who had never worked together before were doing roles that they had never done before. And from a practice perspective, we had to create all of those new roles, their responsibilities and duties. And it was amazing to see how quickly things could get done. I've never seen a medical directive written so fast and approved so fast, but it was, and it did happen. So staff came from all different areas, and our motto right from the start was that tough times never last, but tough people do. And that went on our board, and it stayed on our board ever since. So the center was built in 5 days. We held a 2-day training. As you can imagine, infection control was top on the list. So in order for patients to be safe and staff to be safe, infection control had to be #1 priority. Roles and responsibilities, patient flow, when to escalate issues, all of that was covered in a very, very intense 2-day training. And we were very fortunate to have a number of people help us in this. So that 100 people wasn't just the build, but it was all about education. So lots of our education partners, the Sim Center was paramount in helping us design that flow and really carve out the roles and responsibilities. So we were very fortunate to have a whole group of people helping us. Since that time, we have now done over 10,000 visits, close to 9,000 tests. For perspective, over 15 weeks, that's more than many ambulatory clinics run in an entire year. The early stages, there's nothing really quite like a global pandemic to give us a global common purpose. And I think that's really a huge factor as to why this team has done so well. It was a harness for everyone's desire and passion to try and help and to be part of something bigger. There was tons of problem solving that happened. This group lives and breathes in a PDSA cycle constantly, and we act on them. That's, I think, the key thing. So ideas just don't come up and go nowhere. We constantly change and grow. And we really early on recognized individual strengths. And we were fortunate to have a number of community caseworkers be part of our team, and so they were redeployed to us. We recognized very quickly that with a lot of our no fixed address patients coming through, these individuals were fabulous at de-escalating. And so there are greeters at the door. So things were shifted around and really based on people's strengths. Some of the other things that happened was there was order, but not hierarchy. And what I mean by that is it was all hands on deck. There were times that there is not enough staff. There are still times now that there are not enough staff, and everyone helps out. So where there are clear roles, absolutely that happens. But doctors are putting stickers on specimen labels, and the manager, this is the first time I'm not wearing scrubs in a long time. I will jump in and I'm helping people with their PPE, or I'm scribing for a nurse. So I think that was very helpful. People knew their roles, but there was very engaged and present leadership and order, but not hierarchy. There was a lot of recognition. And that came from one another, and it came from the hospital, it came from leadership team, it came from outside partners and very generous donors that would donate food or coffee or so on, which was very much appreciated by this team. Unlike other scenarios, there was trust right from the beginning, and it needed to be that way. You couldn't wait and build trust. You had to trust and hope that everyone knew all of their roles and responsibilities, and we could build on that as we went. There was a lot of creativity and some lightness, and I'm using this picture as an example. So they wanted to have a photo that said simply what it does: we stop at nothing. The communications team didn't want this photo to be shared because even though we're all in PPE, they were all together in one space. So in order to overcome that obstacle, they created this picture. So to me, this represents that team going from, okay, this was what we wanted. It couldn't happen that way, so we'll find a way to do it. So this photo I find really just a nice summary of this particular team. I'm not going to say that there wasn't storming that happened. There absolutely was. There are many cooks in the kitchen, and that definitely happens. There are lots of ideas flowing. There were little conflicts that happened, especially on the early days when we're trying to figure it out. Is this the right way to do it? Is this the right way to do it? But we got the opportunity to know each other. We talked things through. Communication was very much key, and identifying some team leads, and team leads that were very calm. And I think in a high time of high anxiety, having some real calm leaders around that were always present made a huge difference. In terms of team building, we were fortunate in that our daily huddles, we have a huddle every morning for 15 minutes. It's not long. We have a debrief at the end of every night. It is also not long, but it happens every day. And in the early stages, our CEO of our hospital came to that huddle on multiple occasions, and that really, gave the importance to this team. They knew that what they were doing was important. They had lots of creative outlets, this picture being another example of that. We shared songs, we shared videos, we shared memes. Everybody thinks memes are one of the best things that happened with COVID. So some of the memes, we would start our daily huddle with a funny meme just to sort of create a light environment. They have a WhatsApp group that this team created themselves. This morning when I looked at it, there was 167 different photos that have been shared. And they're sharing just supportive messages to one another. And so that was a very organic thing that happened. And there was a lot of different appreciation that happened, as I mentioned, just, gift bags with coffee and so on. And then, the idea of appreciation is huge. And so those recognition lunches were very important. Leadership is also an interesting part. And this photo that I've got here, which is me on an outreach. So one of the things that we do is we go to different shelters. The shelter that we went to this particular day was a women's shelter, and they had given us all t-shirts that really meant to sort of bring us all together as one group. I highlight this picture because I'm there. Today is the first day I haven't gone to an outreach. I feel kind of like, a mom not going to their sporting event of their kid. You know that they'll do a fabulous job. It just feels wrong not to go and watch it and observe. These are the things that I asked most regularly. Will this plan work? Here's what's going on. Will this plan work? How can we improve? What do you need? I trust you. You can count on me. Don't set the small stuff, and let's celebrate. The expected success factors, the recognition, of course, we always know that. The camaraderie that happened, that common purpose was a huge one. Having some clear roles, but the sense of accomplishment and that purpose. This photo is from Robertson House, which is a women and children's shelter, and the team wanted to make sure that their Tyvek suits didn't scare the kids, so they put stickers all over them. They had funny hats and Mickey Mouse ears, and they did that themselves. They knew their value. They had opportunities to try different roles, be team leads, and so that was a very important, and those were expected success factors when it comes to a team. There are some unexpected success factors, and the turbulence that you talked about in that last presentation and how things are constantly changing, that constant change was actually quite helpful for people. The new challenges, here we are in the COVID Assessment Center, now being asked to do outreach, now having staff leave and go back to their home units. Now being asked to test sort of 6,000 employees or everyone in long-term care. So these constant changes where that might be disruptive to a team was actually quite beneficial to our team. And the fact that staff are leaving and there's a short term, maybe there's an end in sight, is I think also part of the success. We sort of say we're here for a good time, not a long time, although I think it'll be a long time. So I wanted to leave with these two photos. The right side is their creativity. They've decorated some of their spaces with just words of inspiration, such as this coloring page. And then when people leave, there is a Hall of Fame, a wall of fame, where they hang up their face shield because they're no longer coming to the assessment center and they're back to their home unit. And I think that just shows this team has really been solidified and really proud of the work they do. So I'm going to stop there. I'll stop share, and if there's time, we'll take any questions. Okay. Thank you.
Hi there. I don't know if I should go ahead, but I'm going to share my screen. I'm Dr. Peter Selby, and I want to thank everybody for being here and taking the time. So what I'm going to do is just quick, I'm not hearing anybody else say anything to me, so I don't know whether I'm on track or not, but I'm going to go ahead. I'll try to watch the chat just to make sure that I'm not missing anything. Okay, so what I'm going to talk about is technology-enabled collaborative care. I'm going to try to make sure we stay on time and get you back on time. So, all right, so I'm a professor in family medicine and community medicine, psychiatry, and public health. I'm an addiction medicine physician. I practice at CAMH. I'm a clinician scientist and a senior medical consultant, and my whole work is about implementing and scaling up interventions in different settings, including primary care and the community settings. So what I'd like to do is just talk to you a little bit about how we do the challenge that we face is our current standards. Whenever people have any kind of complexity is that they have to go from various care providers from various organizations for physical and their mental health care services. So what happens is they go from location 1 to 3, and even if they need something, it's always a transition from hospital to primary care to a social service. And the probability for people actually making their appointments and staying within that and getting the care they need drops exponentially when this happens. And so people have tried one-stop shops, but again, by limitation, imagine if you had a one-stop shop in a hospital right now with COVID shutting everything down and things considered non-essential going away, people will just get left. So we need to think about this differently. And one of the things I like to tell people is in the rush to respond to providing care during the lockdown, don't digitize the dysfunctional analog world, because as soon as you put it into an EMR or digitized the workflow, it's very difficult to undo something that is sort of been programmed. So let's be very mindful and careful about how we proceed. Now, what I'm going to do is obviously, this is a project that we finished actually prior to COVID. It's been going on for 2 years. It ended in January. This was funding from what's known as a Medical Psychiatry Alliance. But really, the project is called TECHY, Technology-Enabled Collaborative Care for Youth. And I'm just going to talk a little bit about it. This is the team, and the team came from CAMH. It came from Sick Kids. It came from Trillium Health, as well as the university. And these were the people involved at the scientist level. So what was MPA? You can take a look at it at the website of how people joined. And the question is, can we virtualize collaborative team-based care? For this first study, because of the requirements of the funder and where we wanted to go, it had to be youth, young adults, 16 to 29, recovering from a first episode of psychosis anywhere in Ontario. So the idea was, how do we create something that doesn't require people to travel either to CAMH or to any one of our sites, but they could do it from the comfort of their homes or wherever they wanted to. The program was 12 weeks of coaching on a platform, and there's a link to the YouTube video if you want to get a look at what it looks like and what the experience for the patient and the family is like. And the control group was a mailed content, and they had access to the platform, but they didn't get the coach. And the whole outcome was, how feasible is it to do this? And at the end of 12 weeks, do they have any benefit from the program? So we finished our recruitment, and our target was 60 people, but we actually ended up getting up to 65. And just today, I just heard that our protocol paper has just been accepted for publication in early intervention psychiatry. So it should be out if you want to get a description of what it is. Now, we all have heard about collaborative care. The issue with collaborative care models is that they are very resource intensive. They require people to go in analog fashion where care providers have to go into the same setting rather than the patient traveling to them. So these are the 7 elements of good collaborative care. As you can see, patient identification, engagement, evidence-based treatments, systematic follow-up, communication, and care. And in the case of mental health, you want systematic psychiatric case review and consultation with the care team. Now, why a virtual collaborative care model? Because one, it can eliminate or reduce the need for face-to-face visits, allows for triaging of the patient before they see the specialist, supports available to the patient outside of the physician visit. Here's the thing, for chronic disease management, the work that's done in the setting with the care provider is the least likely to affect the outcome, which is determined by many of the other things going around that person, their family, their social determinants, etc. So whether you're managing diabetes or hypertension or depression or any chronic disease, the elements that really matter are what happened outside of the appointment. So how do we make sure that people have those supports at the time where they are? The other piece is that if you virtualize this, you can implement measurement-based care and data collection so that you can give people real-time feedback and you can adapt your treatment based on the data that's coming in. So in this model, we've described it, and I'll just show you the diagram. And the diagram goes from, you can start anywhere. And this care manager, as you can see, is in the middle. The care manager could belong to either the primary care system, the hospital, or any of the community services, or it can belong into a hospital setting, like a specialized center like CAMH, for example, in this situation. But whatever it is, it's redeploying your existing resources to be the care manager. So then what you're trying to do is multiply the effects that you have. So for example, a care manager can see about, for a 12-week program, could see about 40 patients a year, giving 2 hours per week with 80% productivity. And this means that the specialized services, like in this case, the specialists, whether this specialist is a psychiatrist or an endocrinologist or whoever, can multiply their impact rather than seeing people one-to-one. Now they can see in an hour, up to six patients. Through the care manager. Now the care manager is really critical here because they will, and I'll show you in the next slide, that although the care manager can be situated anywhere, they use technology. And when I use the word technology, it's not just video conferencing, it's text messaging, it's telephones, it's whatever it takes. And in some circumstances, it might even need a face-to-face intervention with the patient, depending on their functionality. But what they're doing is they're really the connector. But they are enabled by the technology to be able to be the relationship manager between all these systems so that the patient experience is seamless. So what are the roles and how do we identify these patients? So we can identify the patients with a referral to the care manager. Either the patient can self-refer, or their primary care provider can do it, or on discharge from the hospital, the person can be referred in. Moreover, as we try to get a better healthcare, become a better healthcare system, we need to be proactive, which is I call a seek and treat. Where how do we find people who are in need of our services? And we can look at our data forms, whether it's the EMR, whether it's population data sets, or in my case, we have a large data set of 250,000 Ontarians who we've treated for smoking, who have consented to be contacted again. We can mine those data to see what needs there are and offer help to them. So there are many ways of doing this. The care manager, as I said, is really the relationship and person. They provide the assessment. Because of the algorithms we've developed, they can work with the client to co-create goals, and they consent for the whole team to be part of the care. So whether it's the family, whether it's the primary care, whether it's the hospital, or the virtual care team, which I'll come to in a minute, they are critical. They can implement the quality standard. They communicate between all parties. They provide non-judgmental monitoring and follow-up. Patient and family education support, which can be done online, and patient self-management, which can also be done online. So what this means is everybody doesn't have to go traveling all over the place to get the care they need. Now, what is critical in this model is the care managers typically, if you know, that they get left on their own and they have very little ability to be supervised. Now, what we've done is created a virtual care team where the specialists and whoever the care team members can be anywhere in the province because they are connected via the platform, which is an electronic means. And so they can have a synchronous meeting, which we can, from 11 to 12 every Tuesday, they get together and discuss every cases, and they can do it online. Or let's say the specialist is running busy, or the RT or the nurse is sick. What happens is if they miss it, they can log in and see what was done and provide information. And if there's a key bit of information or advice needed, the care manager can connect with the nurse. Now, let's say the specialist says, after listening to this case, I think I need to see this patient. With the platform, they can jump on it and do a telemedicine visit with the patient. Or the primary care provider here says, I can't attend this meeting when you're discussing my patient. I'm going to send an e-consult. And because we've got that information, the specialist can now communicate that back to the primary care provider, and the care manager can make sure that the patient hears the information as well as the care provider, so that the patient doesn't suffer because of a lack of collaboration and communication. And of course, all these data are being analyzed real time, and we are learning as we go along what this patient needs and what can be done. So it's both conscious and subconscious in the sense that the data is being analyzed to provide insights to the team as to how they can manage that patient. So this is just another model which we call our river of care, where we look at identifying and profiling the patient, engaging them, empowering the patient to fill out through technology a lot of their information. The practitioner then fills out their forms, and then the treatment is developed with the patient and implemented. And at any point along the way, if the care team is feeling stuck, they have all these opportunities to get collaborative care and expertise, whether it's education, whether it's a care team of experts, to help them and manage that. And the platform continues to help them monitor treatment and do follow-up with the patient. And so the idea is to prevent complications. And all the while these data are being collected, they're being analyzed, and automated dashboard for both the patient and the team. So that's our vision. In summary, in this model, the healthcare provider or the person can make referral to the care manager, and there's a virtual collaborative care team. The care manager is critical. They establish the relationship, and they can initiate the standard treatment protocols, present each case to the virtual care team to discuss additional treatment recommendations. The treatment plan is communicated to the patient as well as the primary care team, and you can deploy measurement-based care, monitor the patient's progress, communicate flags or concerns, and as I mentioned, you could see the patient if necessary.
Just time to move along.
Okay, I'm going to stop. All right, thank you.
Teamwork and collaboration are terms that we often hear in healthcare. However, it is important to note that these concepts look differently to different stakeholders. Good morning, everyone. My name is Gobika Sidambaranadan, and I'm here to share my experience and viewpoint on teamwork and interprofessional collaboration as a first-year occupational therapy student at U of T with over 5 years of experience in healthcare settings, taking on various roles. I'll begin by telling a little bit about myself. My family immigrated to Canada in 2010 from a war-torn country, Sri Lanka, where we once again had to reestablish stability. From a very young age, I witnessed the hardships associated with inaccessible healthcare endured by the people of my homeland. This sparked my passion and commitment to healthcare. Both my parents have chronic illnesses, which further fueled my drive to pursue healthcare because of how efficient healthcare teams worked to provide exceptional care. To put my passion for healthcare into action, I completed my honors Bachelor's of Science and currently am finishing my Master's of Science in Occupational Therapy at U of T. Here, I had the unique opportunity to not only learn about theories and framework of working and collaborating as part of a team, but also be able to apply these through engaging in group activities within hospitals and academic settings. Interprofessional education at U of T further supports my personal and professional development through its curriculum, with the primary goal of fostering interprofessional interactions between students in healthcare profession. I've had the opportunity to not only experience the incredible work students do from each profession, but also be able to enhance my collaboration skills by facilitating IP electives and core activities. I continue to develop collaborative leadership skills when serving on multiple working groups where, as a team, we tackle matters and resolve them. I was also able to practice this Canadian competency, Health Collaborative Framework Competency, which is the collaborative leadership, when I contributed to 3 of the 4 subcommittees of Interprofessional Healthcare Education Association at U of T, short for IPSA. Through all these roles, I worked as part of an incredible group of like-minded students, faculty, and staff from Center for IPE, community members, and clinical partners with the focus of enriching the learning experience of students. I have been a volunteer in the Canadian healthcare system for over 5 years and contributed to both clinical and non-clinical research for over 4 years. I served as a Healthy Serve Mobility volunteer at Sunnybrook Health Sciences as well. I also served in administrative, emergency, and clinical research department of various hospitals within the GPA. In my experience as a teaching assistant and tutoring students registered with accessibility services at U of T, I collaborated with students, accessibility advisors, and other professionals within the academic field who may not be experts in healthcare to meet learning objectives. Those with healthcare backgrounds, like me, offer a clinical perspective for enhancing accessibility, while academics can provide their perspectives based on their experience with teaching in academia. Although each person has their own subject matter expertise, teamwork and collaboration are skills that are useful for many professions. The transferability of teamwork and collaboration skills is especially crucial in many settings like these and for many stakeholders. Teamwork and collaboration are crucial in listening and acknowledging the contribution from each person in the field. In my personal experience, having a team that has a common goal, supporting each other, and collaborating well by considering varying perspectives reap the outcome that all members agree on, and are critical components of interprofessional collaboration. Incorporating expertise from each profession helps to meet the common goal of ensuring quality patient care, customer service, research outcome, or student learning objectives. When a team sets a common goal, they draw from each other's expertise and utilize their own expertise to enhance each other's competency in order to excel at a common goal. Therefore, teamwork and collaboration is most successful when the interdisciplinary team has a common goal to offer exceptional care to the population they serve, whether it be students with accessibility needs, as in my case, or patients in hospital setting. As a result, the students with accessibility needs were able to complete their assignments and coursework in a way that they're proud of, since their grades reflected their work and understanding of course materials rather than the barriers they faced, while the professors experienced minimal disruption. Thus, both the students and academics were thankful of the smooth examination experience resulting from interprofessional collaboration. I have seen a gradual yet increase in my understanding and competency with every learning experience where I collaborated with and learned from professionals from different areas of healthcare, whether it be from clinical professions like nursing and physical therapy or research-oriented like public health. I hope to continue enhancing my competency through engaging in structured IPU fieldwork activities where I'll have the opportunity to work as part of an interprofessional team with other learners and clinicians from various professions to support each other's learning. This experience, along with many other experience working part of a team in various settings, will continue to help me develop my competency in team functioning. Given the unprecedented circumstances, teamwork and collaboration is particularly important to ensure the best care possible. When what we felt like suddenly had to move many of our professional occupations to virtual platforms, we needed to make a contingency plan to ensure the objectives of the team were being met. Since I'm in a professional master's program with fieldwork placement, important consideration needed to be made regarding successful meeting the requirements of the practice. As part of University of Toronto, Department of Occupational Sciences and Occupational Therapy Professional Curriculum Committee, PCC, I was able to collaborate with other representatives from PCC and Student Affairs Committee, SAC, to ensure student voices were heard with respect to important curriculum changes that will impact our future practice. In addition, many of the Center for IPE, core and elective activities needed to be changed to an online platform for the very first time. As a result of interprofessional collaboration, our team of hardworking individuals ensured a smooth interactive experience for all despite the change in format. Considering all the inevitable changes that needed to happen, adaptability was proven to be valuable during this time. For example, my recent volunteer role at University Health Network Toronto Rehab Center was suspended due to COVID-19. However, the team ensured that we stay connected while physically distancing through activities such as virtual game night and sending encouraging messages to frontline staff. And we saw some examples of that in our previous presentations as well. Thus, during these unprecedented times, there are many barriers to teamwork and collaboration. However, with commitment, adaptability, and perseverance, a team can successfully overcome these barriers. My experience working in hospital taught me how to clinically reason and provide quality care within respecting institutional procedures by collaborating with professionals from different fields to better understand both patients' need and institutional protocols. My research experience taught me that collaboration is crucial and your team is your lifeline when you want to produce the best quality work. HBSC and MSCOT helped me accumulate essential knowledge for practice, and the Center for IPE further helped me develop my competency, not just as a student, but also as an educator. My lived experience provides me with a unique perspective that helps knit all my professional experience together and drive my passion to becoming a professional occupational therapy who values partnership, enables occupation, and holistic care, which can only be achieved through when profession collaborates with a common goal of advancing patient well-being. Thank you very much for taking the time to listen to my perspective, and I'm beyond thankful for this opportunity. Thank you very much, everyone.
Okay, good morning, everyone.
We're doing a joint presentation. So I guess, Jason, did you want to start or?
So I'll just thank the panel for inviting us to be part of this conversation, and Gobika for the enthusiasm. And it's nice to hear from students. It seems like a long time ago we were in those same shoes and equally enthusiastic. So it helps bring that back a little bit. So it was nice to watch. So we don't have a PowerPoint presentation. I think we're just going to chat a little bit about our experiences over at Pine Villa, and hopefully that'll save a little bit of time and get us back on track. So with that, I'll allow Andrea to take the lead here.
Okay, thanks. Well, thank you everyone for having us. It's actually exciting to hear all the different areas of expertise on the collaboration between the different partnerships. Pine Villa, my name is Andrea Streisfield. I'm the manager of client services and I represent Sprint Senior Care. Pine Villa is a reintegration unit and it exists in partnership with between Sprint Senior Care, Loft Community Services, Sunnybrook Health Center, and we work very closely with the Toronto Central Inn. Pine Villa assists adults in TC Lynn hospitals facing complex health challenges such as mental health, addiction, cognitive and physical ailments to access a safe and supportive environment while receiving assistance to transition safely back to the community with access to enhanced assisted living spaces and services or to long-term care facilities dependent on each other's functional abilities as determined through assessment. Just to capture our collaboration, beginning when we first joined in this project, it was kind of like marriage / honeymoon. We didn't know what to expect. However, all our different agencies really pitched in and really collaborated, really to the point that we were able to win the Sunnybrook award team. So that's just a little bit of an example of our collaborative approach together. The purpose of our collaborative partnership is to provide a community setting that enables our clients to receive clinical support to regain strength and independence outside the home, outside our hospital, outside the hospital, and outside our home as well. Part of our interprofessional team, we have nurse practitioners, which really help guide the clinical team. We have RPNs, which are also called client care supervisors. We have recreationists, activationists, social workers, managers, and we have an MP that is on a consulting basis. Sorry. The interprofessional team brings expertise from mental health and addictions, community support service to improve the overall well-being. And that being said, we have had a number of clients who first came to us that really had no support, nowhere to go, and their health was quite compromised. And at the end of their stay here, we really did find that it made a huge difference. They were able to regain some of their strength and independence, and so much so that some of our clients that were supposed to be going to long-term care ended up changing their destination because of the independence that they were able to achieve here and the strength that they were able to achieve here. Another collaborative approach would be our admissions, which are considered a separate process, but we've been united front throughout the pandemic of all the processes being aligned. So a number of our admissions, reviewing of referrals, and new COVID-related screening of patient protocols. Some of our staffing resources and ideas with LOFT. So we've shared our resources, and we share a space here at Pine Villa. Occasionally it becomes a little bit tricky in sharing the space because we are two separate entities, yet we've come together to really make Pine Villa one. And I know Jason's going to touch on that a little bit later, but our saying is the one team Pine Villa. And it really is shown through all of what we do. We are very collaborative. We meet weekly, especially in light of what's gone on with COVID. It's not one agency, it's two agencies working together to provide the best care, to provide some of the strategies during COVID that we've experienced. Our clients, number one, are feeling a little bit alienated and isolated. So we're really working together, again, collaboratively, to ensure that we provide the best care. So I think I'm going to end there and let Jason take it from there. Thank you.
Okay, thanks, Andrea. So I see that we have 3 minutes left. I'll run through some points here that we've kind of discussed in I think just this Pine Villa project in the age of system change and OHTs, we've really found ourselves in a position where through the partnership, we've almost become a mini version of an OHT. So it was a tremendous opportunity to be leaders, to figure out what could be done on a smaller level and kind of push those limits to see what could be achieved and in these types of collaborative partnerships. Aside from the initial partnership between ourselves, Sunnybrook and Sprint, we added additional organizations to become part of the bigger team. Aramark, for example, was providing kitchen services. We gave up some space to create a wound care clinic in-house collaboratively with the TC Lynn and VHA. This provided us with some additional flexibility in our continuum of care and provided or proved to be invaluable through this pandemic. With the expansions of the partnerships, we recognized that there would be some challenges of enhanced communication and role clarification. We made those adjustments to meet more frequently and separate these meetings into very specific groupings. So we have clinical meetings, we've got pandemic meetings, we've got higher and lower level meetings. We identify key contributors to each meeting and then ensure that the outcomes are shared broadly with the respective teams. Supporting each other's through the highs and lows. So within the partnership, Andrea mentioned kind of removing some of that competitive nature, and that was a big part for us. This was necessary in understanding that, you know, any overall failure of one organization, when one stumbles, we both stumble. It's a failure for both, and it's a success for both. Just keeping that bigger picture in mind was a priority throughout. This is something that we actively work on through team building initiatives in education. Sunnybrook has been a great help in that. Role clarification. With so many experienced professionals, you know, it was imperative that people who have been used to wearing multiple hats and overlapping responsibilities, it was important to clarify those roles.
It's that time.
Oh, is it that time? Okay. So I'll just finish it off by saying that although the organizations want to believe we can do it all, this collaborative approach has proven to be successful as an alternative to working in silos. We've become better, more capable of developing real solutions, hence the adopted motto that Andrea mentioned earlier that we try to reinforce every chance we get, which is the #OneTeam. So I'll leave it there, and I guess we don't have time for questions, but sorry, we've gone over. I didn't expect Andrea.
Okay. Do you want me to start to share my screen? I'm going to go ahead. Okay, can everyone see that? I'm going to just monitor the chat for a sec. Okay, great. So it's a pleasure to be here. I'm Heather Flett. I am a psychiatrist at CAMH, and I'm also the Associate Director of Postgrad Wellness. And I'm going to be talking about recognizing and responding to healthcare worker distress during COVID-19. It feels very relevant during this time, and particularly relevant when we're talking about interprofessional collaboration. I don't have any disclosures. And I'm going to be talking a little bit about how to recognize psychosocial distress and to normalize it, and then some evidence-based and evidence-informed approaches to trying to support healthcare workers during this time. So my orientation, very briefly, I'm a psychiatrist, and I also work for the Faculty of Medicine and Postgrad Wellness. And I think it's helpful to talk about this in terms of a parallel process, because all of us have been impacted by the pandemic and ways in which our roles and our work has shifted or changed to try and respond effectively. Mostly I'm doing virtual work, but also some on-site acute call where I've worked with individuals with COVID-19. And in my wellness role, it's been incredibly busy trying to work with different stakeholders and trainees to support them during this time through redeployment, through quarantine, through illness, lots of things like that. So I'm going to start by locating us at the Second Shanghai Hospital. This is a very large tertiary hospital in the Hunan province of China. And there was a publication that came out in The Lancet in February from a group from this hospital around their experiences in trying to support the healthcare workers at their site during the pandemic. And they had actually developed very formal psychological interventions to kind of preempt the kinds of concerns that they had about their healthcare worker staff. And they found that there was very low uptake. And so they did a study where they reached out to the healthcare workers to try and find out what their greatest needs were. And the majority said that they really needed to have undisturbed places where they could rest, that they required housing and potentially food at times when they were on shifts, and adequate PPE to be able to doff and access these areas of rest and areas where they could eat. They talked a lot about the need to try and manage their concerns about spreading COVID to their families, and again, the need for housing and things like that if they were required to quarantine or if they became ill. And so the hospital shifted gears dramatically and created a lot of practical supports for their staff. We will see what the evidence suggests around this as this is continuing to be studied, but I think it's interesting to note that sometimes very kind of clear and well thought out programs may miss the mark if we're not kind of actively working with healthcare worker communities around what their needs are. So this is a hierarchy of needs that was developed through the British Psychological Society around healthcare worker needs and responses to them during a public health emergency. And we can see here, if we think about the example that I just gave you from China, that really the basic needs and physical resources were not met for the healthcare worker staff. So trying to look at psychological interventions, which are at the top of this hierarchy, were very much inaccessible to staff at the time, and that we need to really think about staging supports, thinking about this hierarchy. We're going to move now to Stanford Medical School and Icahn School of Medicine in Mount Sinai, and two authors of a paper that came out in April did a really interesting initial study, and they're continuing to follow this with a number of different healthcare providers, and they created these listening circles where they asked staff what would be most helpful from institutions and leadership to support them during the pandemic. Now, this is a busy slide, but I put this up here so that people can refer to it later on. But basically what they found from these groups, and these were kind of well and diverse groups across different health professions, was that workers very much wanted to feel heard and wanted their opinions to be considered, not in all decisions, but certainly that there be good communication bidirectionally around changes in policies. They also had a concern about wanting to feel protected by their institutions and leadership in terms of provision of PPE and potential accommodations for those that increase risk of consequences of COVID. They wanted to feel prepared with access to effective training that was just-in-time learning, and to have good backup and access to expertise if they needed it, if they were redeployed. And this idea that nobody would make difficult decisions around resource allocation alone to try and minimize moral distress. They also wanted support around food and housing and transportation if people became unwell or required to quarantine. And this idea of psychological first aid, which has a lot more to do with peer support and informal kinds of psychological support as opposed to more formal. And then really this overarching need to feel honored and acknowledged by their institutions, and that this should be not only provided by the community, but by institutions themselves. So there's some different examples of gratitude. I think it's helpful to think a little bit about response phases of healthcare workers during a pandemic, and that this changes over time. The preparation phase is very much a rapid time of decision making, and there can be a lot of anticipatory anxiety on the part of healthcare workers. This is probably what we were experiencing back in the middle of March during the March break. And then moving into the active phase, sort of early on, a lot of camaraderie and heroics, a lot of kind of ramping up of energy to try and meet the demands. And over time, moving into the second phase, which is called the kind of infamous third quarter. You may have read about this or be hearing about this. this is really where healthcare workers start to kind of shift into periods of exhaustion, where energy starts to wane. There can be a greater blurring of kind of personal and professional boundaries. We're seeing that both in people that are working on the front lines and a lot of people that are working virtually around trying to manage personal and professional. And sometimes the way that we behave professionally can start to shift, particularly if there isn't role clarity. And that's something that the folks at Pine Villa just spoke a little bit about. And so to be aware of some of that and to be intentional around trying to manage that. And then the recovery phase, where there's an opportunity, there's slowing down, an opportunity to try and reflect a little bit and think about post-traumatic growth. I think it's helpful to know from the literature that the majority of healthcare workers find the experience overall can be quite positive, and that there are a lot of innovations that are discovered through some of these exceptional times, but that there can be a significant amount of post-traumatic impact as well. And that can be managed and mediated through different responses that I'm going to talk about. So obviously, it's very important to try and align responses and supports with the needs of the population of healthcare workers. Some of the things that we've seen are the provision of food, provision of housing. Here in Toronto, we've had a lot of corporate citizenship around donating Airbnb space and different hospital space to trainees and staff. Retraining opportunities that are virtual and online and available for those that need to be redeployed, and a confidential and accessible kind of system for accommodations if people require that to be removed from certain settings if they're at increased risk or high risk of developing consequences of COVID. Psychological first aid, and this is really kind of more informal peer support and not formal, not professional kind of psychological and psychiatric support. And the underpinning theories of this have to do with trying to maintain a sense of safety and calming in the workplace, and for healthcare workers, a sense of connectedness and self-efficacy and an installation of hope. And I have a couple of links at the bottom around designing and facilitating a team check-in, if that's of interest for any of the teams or groups that are on today. Community and social connectedness is key. This is a group that I'm involved with through the ECHO project at CAMH. And it's provided Wednesdays and Fridays on a weekly basis, and it's offered to all hospital-based healthcare workers in the province of Ontario. I can send out more information, or you can contact organizers of this group if anybody's interested. It's free, and it is not treatment. It's an informal community of practice where we really focus on how we're coping with COVID-19. The buddy system, this has really been championed through military settings and also through a team at UHN. And I know that this has been implemented across a number of sites within Toronto, and really thinking, again, intentionally about buddying up with somebody, setting a specific intentional time to check in and make it a regular part of your day. And again, not thinking of ourselves in formal treatment kinds of roles when we're buddying up with colleagues, but listening from a place of understanding and trying to offer support and normalize our experiences. Personal protective relationships. So this is something that was developed by two colleagues of mine, Pierre Bryden and Julie Nagy. And the whole idea of trying to really think kind of after PPE, to really think about how we can use our professional relationships to support each other and to really be compassionate when we see someone's professional behavior potentially slip, because people are going to be exhausted and they're going to be very distressed during this time, and to try and think about how we can support each other. Again, there's
Just
a couple
that
of links
time.
on this. Okay, thank you.
Good morning. Just going to share my screen here. There we go. Can we see that? Okay. Just a second here. Okay, so we'll get started. I'm just not seeing the chat here, so I just want to make sure.
Your slides are good.
Okay, thank you. So good morning, everybody. My name is Kayla Bisacco, and I'm the Capacity Building Coordinator on the Patient Education and Engagement team at UHN. I'm co-presenting this morning with Farah Schwartz, who is the manager of our Patient Education and Engagement team. So our focus today is on how we've stayed true to our values by continuing to partner with patients throughout the COVID-19 pandemic, including how we've really relied on interprofessional collaboration during this time. So thank you so much for having us. So
We wanted to start by sharing this tweet, which is a response to the notion of Dr. Google, where a healthcare provider might think about a patient's experience like, don't confuse your Google search with my 6 years at medical school. And what we see in this tweet is a response from a patient saying, don't confuse the 1-hour lecture you had on my condition with my 20 years of living with it. And the reason we shared this is because this tweet really calls out the knowledge and power differentials that can exist between patients and healthcare providers. And so part of our focus in patient engagement is to recognize that both patients and healthcare providers have important roles to play, and that there's knowledge and experience on both sides. And so for meaningful patient engagement to occur, we need to focus on it and make sure that we have the right skills, attention, and infrastructure in place to support it in order to hopefully avoid situations and dynamics like we see in this tweet. And this is similar in a sense to interprofessional collaboration, because we also need the right skills, attention, and infrastructure in place to support meaningful interprofessional collaboration. So for a bit of context, at UHN, we've been working towards 2 main goals to support patient engagement. And these goals align with the 3 main ways to engage patients that are outlined in Health Quality Ontario's patient partnering framework. So our first goal at UHN is to engage patients in personal care and health decisions. So this refers to patient engagement at the level of care and how healthcare providers partner with patients and caregivers in shared decision-making. So this work is supported by our patient education and engagement team, as well as the MyUHN patient portal, which provides patients with real-time access to their health record, and also our patient and family libraries, which offer reliable and up-to-date health information to patients. The second patient engagement goal at UHN is to engage patients in program and service design and policy, strategy, and governance. So these refer more to patient engagement in organizational decision-making and planning. So patients and caregivers are engaged in quality and safety improvement initiatives so that we can work towards a better patient experience. And this work is supported by our team of just over 120 active patient partners who are engaged in initiatives such as committees, focus groups, and hiring panels. So for example, a patient partner was included on the hiring panel when our most recent CEO was hired. And then this work is also supported by our patient relations team who help address the questions and concerns that patients have about their care experiences at UHN. So the work of patient engagement at UHN has been building momentum for the past 5 years since patient engagement came together as an organizational program. When COVID-19 started, of course, things really shifted and organizational priorities immediately shifted to things like infection prevention and control, of course, but we knew we still needed to focus on engaging patients. A lot of changes were happening. There were changes to services and visitor policies that removed key partners from our sites. Information was changing really rapidly and unilateral decisions were being made about patient care and policies. Deadlines were really tight with minimal flexibility to change, but we knew that we still needed to partner with patients to make sure the patient voice was heard and inform the work that we do. So we asked ourselves kind of 2 key questions. How do we engage patients in a meaningful way, even though the circumstances are different? And how do we shift in order to make these changes happen really quickly? So most of our teams were working remotely and we couldn't invite patients to our sites. So all engagement was shifted virtually. So the photo you see here is actually a group of new patient partners who had their orientation over Zoom. We also really relied on established relationships and trust that were built with patient partners and that contributed to a successful shift in this virtual engagement. The patient partner team identified a group of about 20 patient partners who could provide really rapid consultations with us in the changing environment. And then the main focus of our patient education and engagement team has really been on patient and family facing communication. So we've been focused on the immediate information that patients and families need to know.
Thanks very much, Kayla. So to further illustrate how we were able to partner with patients and families during this time, we're going to focus on the example of the no visitor policy that came into effect in March. So as you're probably aware, one of the immediate changes in hospital processes across Ontario when COVID hit was to limit who was coming into the building, and family and visitors very quickly weren't allowed in. We were hearing that there was a lot of frustration at the entrances, so a lot of patients who were showing up didn't know that they couldn't bring anyone in with them, or they weren't prepared to really accept that in such an important care moment. So there were a lot of reports of hostility and incivility to screeners, and it was really quite hard on everyone, especially the patients. So So we had to figure out how can we continue to focus on patient and family needs above all else, despite the restrictions that brought in so many other priorities. So the first thing we did was we went to a group of patient partners and we asked, how can we work with people coming through so that they understand why this is so important right now? And it was also really important for us to use role clarification there so that we could communicate what could be influenced and what we couldn't. The main themes that came through and what we really learned were that the use of language was very important. So often in patient education, we'll try to use the most plain and clear language. And we learned that in some cases, the specific term that we thought was most clear might actually have harmful impacts. So for example, the use of the term alone. If we said something like, you have to come in alone, we got feedback that actually that was very scary for some people. We also learned a little bit more about the caregiver experience. So what it must be like for the caregiver to leave a patient for an appointment and also have nowhere to go even to use the bathroom because of everything being shut down. The patient partners also provided really specific ideas and solutions that weren't in place yet in the early days of COVID. So for example, making sure that we were phoning all patients before their appointment to be clear about no visitors being allowed, to remind patients and visitors of the importance of why there was no visitor policy in place. So emphasizing that in some areas, patients may be immunocompromised and that a COVID outbreak would seriously impact their family members and loved ones. We also put in programs to escort patients to appointments if they would normally need help to get there from their care partner. Having someone at the door if patients and visitors have questions, need help or directions. Also guidance on how family members could use devices to connect with their loved one or during a care meeting. And then most importantly too, having a notice on the portal. One thing that even came through was we had a patient partner offer that one of our team members could shadow her next appointment to see how it was going. So we used all this information to develop communications and to also recommend some programs that could be put into place to help both patients and caregivers. And also we had a patient partner write a resource for other caregivers on dealing with these challenges during COVID and a list of places to go in the downtown area. So it was so important during these processes to really have clear team functioning, collaborative leadership across the hospitals with patients and also with others who were implementing these programs. And then of course, role clarification and clarification of expectations about what we could actually do or impact during COVID. And what you have here are a couple of quotes of what we heard back from patient partners and really meaningful information. So to wrap up some of our key takeaways, even under a lot of pressure and very challenging times, we've continued to engage patient partners in a meaningful way and really do our best to keep patient-centered care as our top value. By focusing on interprofessional collaboration, we were able to really stay true to those goals and values, even during difficult times, use a collaborative approach and shared decision-making to navigate these changes to care and services. So for example, the introduction of the no visitor policy, and now as we're relaxing some of these limits on visitors slowly with the province, we're still using the same approach and continuing to build in the shared decision-making once again as much as we possibly can. This also has really helped us strengthen existing partnership with patients and across teams around the hospital. So we have a lot of new partnerships now as a result of this work. It hasn't been perfect, and these times have been really stressful for everybody. And these policies, especially ones around visitors and patient limits, have been very challenging and frustrating. But by collaborating to arrive at a solution that worked from a starting place, it really did help center the patient voice and experience and set us up for ongoing collaboration and consultation to really ensure that patient voices are present and heard during COVID times.
Just that time. Thank you.
Good morning. My name is Jack Ireland, and I'm a patient partner with the University Health Network. I hope everybody can hear me and understand me. I have a little bit of a speech problem because of my cancer. My personal journey began in December 2014 and ended, well, it really hasn't ended yet, but my treatments ended in January 2016. I was diagnosed with squamous cell carcinoma, stage 4, in October 2015. I had a biopsy, a tracheotomy, and then I had a G-tube inserted at Toronto General Hospital. My treatments at Princess Margaret began on December the 4th, and I had 7 weeks of radiation and 4 chemotherapy sessions. During this phase of my life, I processed the news that I had cancer, that I would need biopsy and inclusive tracheostomy. Coupled with the stress of diagnosis, I had not had anything to really eat for a year. So I was down 70 pounds. And I gotta tell you, it's not a great weight loss program. I wouldn't recommend it to anybody. While in the general hospital, I was fitted with the G-tube and the tracheotomy. And I had a trach for 11 months. And I have to tell you, the most stressful piece of my recovery was maintaining that trach for 11 months. I was never so happy to get it taken out. One benefit I had, though, was I was given preferred seating on TTC whenever I went on with my trach, because I either frightened people or at least I had a lot of compassion. I must say, the kindness in Toronto with the general public is amazing. During the time that I was at Toronto General Hospital, I was given great treatment and education. I have a very high pain threshold, and I didn't want to take any opioids because I'm scared to death of opioids, and they also make me ill. So what I did is I had a consultation with a nurse. She said, you have to take pain medication in order to heal. So we settled on codeine and finally a Tylenol extra strength. You know, Princess Margaret, the care from clinicians, technologists, nurses, intake professionals, volunteers, and doctors that are a whole new level. You know, once I was plugged into the system, I had an initial visit to get a mask made so they could perform my radiation treatments with accuracy. The mask process took about 30 to 45 minutes. The technologists were amazing, and they were really, really helpful to me. So they were very patient with my questions. You know, you go in and you're frightened of having this goop poured over your face, and fairly quickly, about 17,000 questions. I started emptying in the process. Can I breathe? Am I going to make it out alive? But it was really a really interesting experience. My first visit at Princess Margaret was one of awe and misconceptions, because I walked in and all I saw was this factory. What I didn't realize was layered onto this factory were the people who really took care of me, from blood work to oncology, dentistry, the radiation nurses statement, chemotherapy to psychology. There was a method that fit my routine and regimen for treatment. It's fascinating to me. In the middle of all this was my personal care from my partner Paula. She researched my cancer, feeding tube management, my chemo brain cramp, my fatigue, and engaged me to create a sanctuary at home that allowed us to prosper and really thrive throughout this whole process. We had lots of laughs. There were some frustrations, and I must say, I expected to put a pillow over my face a few times because there were certainly those frustrations. But I could breathe with a trach, so the pillow over my face would have just been a slapstick comedy routine. I was mute for about 12 weeks after my treatment ended and my recovery began. I think this allowed me to listen a little more and figured out the discovery to thrive. My lifestyle includes meditation, exercise, social field trips, pre-COVID of course, and volunteer work as a patient partner. I'm most proud of the work I engaged within the various committees because it provided me with life-changing experiences. One of the most satisfying committees I worked with in teams was Teach Back. In Teach Back, I was taken way out of my comfort zone. In Teach Back, my role was to provide my story and talk about a time when Teach Back was not employed and provide a time when Teach Back was engaged. I also was involved in making Teach Back training videos, and that was really quite interesting. At the end of the day, I have to say that the collaboration with me and all the people that engage in my healthcare, as well as my family and friends, was really, really important for me to become my recovery. My recent visit to Toronto General, because I broke my thumb, was a lesson in the screening process being really collaborative and well put together to help me as a patient. And I find it, I can't say enough about that. Anyway, I think I'm coming to the end of my presentation. So thank you very much. Have a great day, and thank you for inviting me.
Hi everyone, just testing the audio here. Hopefully everyone can hear us.
Sounds good. You just need to put it to full screen present.
Great.
Perfect. Thank you.
Thank you guys for joining us for our presentation entitled Capturing Key Learnings About Interprofessional Core Competencies in Action as Experienced by the D4 ICU team as they evolved in response to COVID-19. My name is Hamada Keel, and I'm one of the physiotherapists that worked on the unit.
And my name is Nicole Amiro, and I'm one of the social workers on the unit.
So to begin, I'd like to briefly discuss the unit itself. The COVID-19 unit was formed in order to streamline care for patients during the pandemic. And initially, staff were recruited from all areas of the organization on a volunteer basis. The unit originally consisted of 8 ICU beds and 15 ward beds, but later transitioned to a full ICU about 4 weeks into its inception. One key novel feature of the unit was the implementation of alternate hub-based models, which were an important strategy to support increased ICU needs across many acute care hospitals. An alternate hub-based model consists of experienced critical care nursing team members working together with acute care nurses to provide safe care. Along with the nursing staff, there were many other professions and some new roles highlighted in red on the slide that came together to collaborate and provide patient-centered care as an interprofessional team. Our presentation is structured around the core competencies and how they were implemented on the unit. So let's begin with communication. One essential time of the day to implement communication was during our daily staff safety huddles, where we discussed patients, infection prevention and control policies, research trials, and medication changes. Interprofessional members also had dedicated time at the end of these rounds to provide updates that were specific to their profession. As well, there were daily medical interprofessional rounds that were focused on care management, and these rounds would be held at the bedside daily. Lastly, it's important to remember that patients and family members are also an important part of the interprofessional team. The use of technology to facilitate patient and family communication played a key role on the unit. There were visual monitors to observe patients outside of their rooms, direct phone lines to communicate with patients, and hands-free devices to limit exposure for team members. Because of the iPad initiative, patients were able to FaceTime family members on the unit as well, which would prove to be valuable in light of the visitor restriction policies. As there were interprofessional staff from multiple sites and areas of the hospital, clarifying everyone's role was an essential part of forming the team. A simple tool we used to do this were role identification stickers, as outlined on the slide. Role education, indications for involvement, and co-treatment opportunities were done on a personal interaction level and case-by-case basis. However, the variety of skill sets and past experiences in terms of patient populations, patient acuity levels, team structures, all added to the breadth of the team's knowledge and created many teaching and learning opportunities for staff.
Decision-making on the COVID ICU was done by all interprofessional team members as well. So this was seen through the daily interprofessional medical rounds that Hamad mentioned. This was done at the bedside, but on this unit specifically, it was done outside of the room to preserve PPE. This was to determine patient issues or concerns and decide how to best address these concerns and who would be following up on this. It also helped to identify the daily updates that would be provided to the family, which was extremely important as they couldn't be at the bedside. Early disposition planning was done by Allied Health and the medical team to discuss the optimal disposition plan for the patient. This guided the orders for PT and OT. We were doing a lot more discharge planning when we had ward patients, but as we transitioned to ICU, PT, OT, and social work, early assessments guided the treatment plan and the patient's route through the hospital. Infection prevention and control played an integral role in decision-making for patient care as well. This would impact the patient's length of stay on the COVID unit versus their transfer to a regular ICU or ward. IPAC guides the precautions and the recommendations for PPE that all of the team members were following. Finally, patient and family values were being taken into consideration for all patient decisions. We involved them in their own care to discuss their values, their goals of care, and have those really important advanced care planning conversations. Often in the ICU, and specifically the COVID ICU, we were having these discussions mostly with the power of attorney and the substitute decision maker. Conflict resolution on the COVID ICU. So we faced a lot of challenges with the no visitor policy, and the team worked to advocate for exceptions to this given the needs of the patient. The IP team would provide reasons why the patient, the family, or the team would benefit from a visit from family, and would work to resolve this conflict with the assistance of the patient care manager at a director or operations level. The only constant on the COVID ICU, along with most other units at this time, is the constant change that we're seeing. The challenge of constant changes to the nature of the unit, including new staff, policies, IPAC protocols, and everything else, the interprofessional team worked through this conflict by using effective communication strategies and really having an open dialogue with one another. Interprofessional staff coming from various areas of the hospital allowed for a lot of mentoring and education between and among staff who came from different services and different units. The hub model that Hamad spoke about was a completely novel model, so we faced a lot of conflict around this as well. There was a lot of misunderstanding related to the role following redeployment from unit of origin, so not knowing exactly what your role was going to be when you arrived on the unit. To resolve this, there was a staff touch base geared towards the nursing staff on Wednesday afternoons, specifically to share understandings and perspectives. Due to the novel nature of this unit as the COVID unit, our interprofessional team does not yet have a defined set of values and ethics that are separate from those that Sunnybrook holds as an institution. This is something to be further explored and separately defined by a group of IP members working on this unit. Also, there's not been a lot of structured reflection in regards to processes and the workings of the unit to this point. The staff have engaged in lavender alerts with spiritual care, which has provided individual emotional reflections and debriefs and have proved to be very helpful for staff. These are competencies that must be explored further and worked on amongst the team. My personal experience on this unit does not reflect that of all the interprofessional team members, but I found the environment to be extremely supportive, as it felt as though we all went through the unknown together. Finally, we want to acknowledge Melissa Adamson, the clinical educator on D4 ICU, D4 COVID, and other units on the hospital for her help with this presentation. Thank you so much.
Good morning, everyone. I'm Lynn Sinclair, and I'm the External Development Lead at the Center for Interprofessional Education. I have the pleasure this morning of co-presenting with Dean and Dale, who will be introducing themselves. We're thrilled and honored to be sharing our story with you, and we have called our presentation a virtual boost to mental health teams, the interprofessional care competency development across the continuum and across the screen, the literal screen, with mental health organizations and networks. Our hope today is to share a story in the version of the why, the when, the what, the who, the how, and the what's next. So first, the why. The Canadian Mental Health Association is a wonderful organization that provides community-based mental health care to a variety of clinical areas and across the spectrum of the patient continuum. And they approached us because in 2018, they had gone to a collaborative care structure. So they wanted to support their clinicians and their intersectoral teams to really work well together. And so they approached the center in the hopes of providing an education to support their staff. So the when. We're calling this the pre-COVID plan. So they first reached out to us in early January, and we worked with them for about 3 months, dreaming, hoping, and creating the needs assessment to figure out what would best support the staff. And the plan was that we would hold a 2-day face-to-face workshop being held on April 2nd and 3rd, and that we would follow up with a leadership consultation a week after that. So we had all our plans in place, and we're feeling really excited and empowered to support the staff with this work. And then COVID hit, and we've shown this slide in an SBAR, a wonderful interprofessional communication tool. We, as everyone will recall, we had a quick Ontario declaring a state of emergency. So the situation was that all non-essential work and all travel were immediately halted, knowing that we couldn't be there face-to-face with our colleagues and to offer this training. So the background was that UHN, where our center lives, was told to postpone all programs. So we were sent a communication immediately to forward to our clients that we could no longer support this face-to-face. And we were invited with a recommendation to consider what else could be possible. So our new when became an 11-day story of discussing with our clients what else could be possible, what else could we do that would support the staff during this time. So we did a very quick pivot to plan a virtual workshop. We decided to keep the original dates, shorten the time frame, but repurpose our content and our materials to suit the staff in this virtual workshop. And now you're going to hear the what.
So thanks, Lynn. My name is Dale Keel, and I was also really pleased and honored when I was asked to be a part of this. So for the what part, what we really did was we adapted a 2-day session on Boost, which is a team-based care workshop. And what we did was we got creative and we divided it up into two 2-hour virtual sessions. And it was really geared towards mental health providers, but they actually were for multiple teams that were participating through individual computers. So as you can imagine, it was not only are we bringing these teams together that may not necessarily have worked together for very long, and now we're having them to do all these sort of activities and participate in an online format. And following that, there was an additional 1.5 debrief and a strategy consultation that was done by, that Lynn actually facilitated with that group. Next slide. The who. So this, again, just is a bit of a makeup of who actually belonged, or who were the members that participated. So you can see in the first workshop, we had 33 participants. And when Dean and I first initially organized this, we thought, okay, what's the attrition rate going to be like? Are people going to drop off and we're not going to see the same number? So we were really surprised. If you see there by workshop number 2, basically the numbers remained the same. And then for the leadership consultation, there were a total of 15 that participated. I think we can go to the next slide. So we wanted to just start off also by saying, for anybody that's not familiar with the National Interprofessional Competency Framework, that we put it there on the left side or the right side of the slide for your information. But what we wanted to really cover in those 2 sessions, and if you see our learning objectives there, we really wanted to help the teams to be able to understand the importance of why collaborative care and teamwork is especially important in mental health. And we certainly know as well that trying to be able to apply some of these collaborative competencies in different roles and different services can certainly be a challenge. But we certainly know with these teams, because they're community mental health teams, that there's additional challenges trying to deliver services here. So again, if you look at, that's where we got into the third point here around resiliency and collaborative mindfulness. And I'll talk a little bit about that in a slide in a minute. But what I would say again, why we were stressing the importance of this is that with other healthcare issues, mental health disorders are often chronic relapsing conditions. And so the members of the teams that were supporting, whether they were ACT teams or intensive case management teams, were really supporting very complex clients and cases. And so this whole notion of, we know that they're stigmatized, we know that it's a marginalized population. And as a result of that, we want to have really solid team resilience and collaborative approaches. And so we really did want to harness, again, on the resiliency and being mindful, not just individually, but also on a team. So if we could go to the next slide. And again, here are some examples. So Dean and I would have ideally done a variety of probably little activities if we were face-to-face to be able to do this, but we had to adapt it a little bit. So what we did, we took exactly right from the CMHA website themselves and tried to talk about, okay, these are some individual strategies. So you could go for an individual break, or you could have meals together or take breaks together. Rather than going for a mindful walk for yourself, why don't you go with a colleague? And I know for myself, with COVID and working on an inpatient right now, whenever I have 1 or 2 colleagues that say, hey, do you have 15 or 20 minutes? Do you want to go get some fresh air? It really feels like that, you know, that saying, a breath of fresh air, it really does feel like that. And it does really try to help to reduce sort of your isolation. So I think we can move on to the next slide. Yes. So again here, this was a purposeful strategy that we included here, which was what we really wanted to do is focus again on how can we promote team resiliency among these mental health teams that are working in the community. So again, we looked at and we offered some ideas and some suggestions. Again, being mindful of each other, And we also talked about maybe it's when you, at the beginning of your shift, maybe it's about doing a quick little check-in, or I think that comment maybe even came from the participants, that one team actually said when we first meet, that we spend 5 or 10 minutes just doing a check-in, so we get a sense of where everybody is going. And then I think the other piece here, okay, yeah, how to create psychological safety. Keep moving me along, thank you. Again, here what we wanted to focus on, again, is rather than about thinking about it from learning problems, but how can we as a team address it? So acknowledging your own fallibility. We all make mistakes. That saying, to err is human, but knowing that you're part of a team also should allow you to have some support and that you're not in this alone. And the last point there about taking a really curious learning stance by asking questions of your colleagues. Why would you do it from this perspective? Help me understand a little bit better. And all these were intended, again, to try to help to create some psychological safety.
Great. So we wanted to just highlight the how, and this will just be, you'll see some of the information here, but it was basically using a combination of interactive activities, small group breakouts. We had them in interprofessional and intra-program, so they could actually work on some of their program objectives to leverage their current work. We also tried to use Zoom features and simulations, as well as sharing stories, but we needed backup plans and more backup plans. The logistics were really key. So like you can see here, we tried to really give them as much orientation as possible to Zoom and to actually video conferencing. We used team norms to look at how we actually might interact to make sure that we're really mindful of our own communication. And one of the things we really try to do also is thinking about how to actually use trigger questions and how to actually—
Just got time, folks.
No problem. An open and non-judgmental environment. So you can see the evaluation results. And just my last point is we actually have transitioned this into a new program called VITAL and Virtual Interprofessional Teaching and Learning. And so stay tuned for that. We're going to actually have new program that we've learned from this, this program. Thanks very much, everyone.
So hi everyone, my name is April Huang and I am currently an advanced practice nurse educator at University Health Network.
My name is Sherry Darling. I'm a speech language pathologist at Toronto Western Hospital, UHN. April and I are here to talk, to share our experiences during the pandemic, redeployed at 2 long-term care homes with Rakai Center. I think we could easily talk about this for 5 hours, but we're going to try to keep it to 10 minutes or so. I've had a chance to chat with a number of my UHN colleagues who were also redeployed, including Rosa Safe, who's a medical radiation technologist with UHN. I know Rosa's listening today, so I'm thankful that she gave me her blessing to share some of her stories with you as well.
So first, some background. The Rakai Centers are not-for-profit long-term care centers in downtown Toronto, and currently there are 2 sites. So one at Sherbourne Place with 126 beds, and also at Wellesley Place, home to 150 residents. And this includes a dedicated 25-bed unit area for residents living with Alzheimer's. So the COVID pandemic, as we know, has hit the long-term care sector more than I think anyone expected, and Rakai Centers included. And so in mid-April, with only 20% of staff reporting to work, Rakai reached out to hospitals, to military, really anyone who could help with their dire situation. And in addition to a critical shortage of personal support workers, nurses, kitchen staff, and other support staff, there were multiple deaths of residents, which people had known for years, and so that led to further trauma. And the staff in the buildings really had to rely on one another for support, and it was clear that external help was needed. And so UHN heeded this call, and our CEO, Kevin Smith, was able to connect with Sue Graham-Nutter, the CEO at Rakai Centers. And on April 16th, our CEO had sent out a UHN-wide call for volunteers to help provide some much-needed stability. And the response was incredible. More than 70 UHN staff, including nurses, social workers, physicians, technologists, physiotherapists, speech language pathologists stepped up to volunteer. And for myself, to give a bit of context, as an educator on the surgical units at Toronto Western Hospital, I myself saw that email as well from Kevin Smith. And at that time, surgeries had effectively been put on pause. And so there were no more elective surgeries. And in fact, we were consolidating what patients we had and moving them to another unit, leaving capacity for the surge that we anticipated might occur. And so when it looked like this surge might not happen, I looked at that email and thought, maybe I could be more useful in long-term care. And so I reached out to my director, Brenda Perkins-Meingas, who has been an incredible champion, mentor, support throughout this entire journey, and really was the one who offered the role of this UHN lead position at Wellesley Place. Jillian Gravely, another educator from Bickle Center, became the UHN lead at Sherborne. And really within 2 days, we were on site.
So just like April and many of my colleagues, I jumped at the opportunity to make a contribution in long-term care when we realized the impact of the pandemic on the sector. For a little less than a month, I worked at full-time at Sherborne Center as a personal support worker, not a speech pathologist. The COVID Care online learning platform that Maria mentioned during the panel discussion, as well as some of the resources from UHN's Redeployment Center, gave us the practical information and theoretical knowledge that enables us to pivot into our new roles as best as possible. But the learning curve in many ways was both steeper and deeper than even I expected. The biggest learning that first day for me was a concrete demonstration of the importance of interprofessional communication and role clarity. When I was partnered with a PSW who had graduated from her program about 5 weeks prior. So it was not surprising that her understanding of the role of the SLP was as limited as my understanding of the role of the PSW. So often we make assumptions about the knowledge and skill sets of healthcare providers. It became clear that it was crucial that I communicate well with everyone, staff and residents alike, about my gaps in knowledge and skill so that they knew what I needed to learn and how to teach me. Also in the panel, Tracy mentioned that secret sauce that's needed to help us feel well and confident as we face uncertainty. I would agree our leaders are a big part of that. So as site leaders, April and Jillian were constant supports for us as we navigated our new working relationships and deepened our understanding of our new roles. Through their collaborative leadership, they empowered us to provide the best support possible to our new teams.
And through this transition into the site lead role, we really wore multiple hats. So as supports the RCI leadership, as educators when we were onboarding UHN staff into this new environment, as infection prevention and control practitioners, making sure that the equipment was safe, available, visible, and that the appropriate protocols were being followed. So the mantra we really worked with was that we're coming in as supports, there to collaborate fully with the team at RCI and really not to take over any operations. So collaborative leadership, and we've talked a lot about that, as well as the interprofessional communication, were two of the most important competencies for us. And this was really encapsulated by the safety huddle. And I know that the Sunnybrook team had just talked about this as well, which we did with staff each morning. And this was implemented jointly by the RCI and UHN leaders in order for us to bridge the gap that we had found in sharing up-to-date information, really hearing concerns from that frontline staff. And also, we know that safety huddles has been regular practice at UHN and continue to be such a valuable tool for us to connect with leadership, as well as having just a safe space to speak up for safety. As we've talked about previously, with having that psychologically safe space. And at RCI, we saw that it allowed everyone on the team to also be on the same page, to hear the same information, to know also how to hold one another accountable. This also became a forum for people to voice concerns, to be raw and vulnerable, as we talked about before, and to reflect on experiences and practice mindfulness as we were coming out of the outbreak in those last few weeks. In fact, it became quite emotional and cathartic for everyone to share those experiences. And very simply, this huddle started with us talking about looking forward, looking backwards, are there any safety concerns, and then making sure that we were taking a turn introducing ourselves with each person. And concerns range from this door isn't working to this resident's appetite is not as good as before. And so these huddles provided also a space for everyone to show gratitude at the end of the day for the amazing work that everyone was able to do.
Yeah, safety huddles were also a very productive way for the team to resolve conflict together and deal with some of those safety concerns that April mentioned, such as things like responsive behaviors. We learned from the Rakai PSWs that have such strong relationships with residents, how to use validation therapy to support the residents in feeling safe and secure. They were isolated to their rooms, sometimes to their beds, and the negative impact had some pretty significant responsive behaviors as a result. We were able to support staff with that. Biggest challenges were how to work within the scope of the role of the PSW and still use our skills and knowledge of our primary profession. But it gave us really wonderful opportunities to highlight the value of expanding the team to include other team members in certain situations, and our learning was just exponential. So just wanted to say, I know we're running out of time, just wanted to say that the learning was just so incredible from the residents who I got to learn how to change a colostomy. I learned from UHN staff how to demonstrated deep compassion and shared their knowledge. Most of all, from the PSWs and nurses and other staff at Rakai who seem to be never-ending wells of compassion, who work tirelessly with dedication and devotion to the residents who they see as family, who even with temporary pandemic pay earn only a fraction of what they're truly worth. Our collective experiences really reinforced for us the importance of our humility in not knowing, and that no matter what we are or where we are and what we do, we can't do this thing called healthcare alone. We need to be part of a team. It includes our patients, clients, residents, our families, and we need to purposefully and thoughtfully reflect on and build our skills in collaboration. Thanks, everyone.
Thank you so much.
Hi, everybody. I'm going to share my screen. And start presentation. Okay. So again, thanks for inviting us to speak. My name is Ran Manner. I'm the Director of Innovation at Baycrest Health Sciences, and together with Kaylin Freeman, who's our professional practice chief for nursing, I will talk to you, or we will talk to you about the experience that Baycrest had around the rapid development and implementation of virtual telemedicine practices during the COVID pandemic. This is part of what we call the TRIM team, the rapid implementation team that was telemedicine implementation team that was put in place. So just a bit about what we're going to talk about. The establishment of TRIM will cover the why. So why are we doing this, our mission, the what, a bit about what the telemedicine that we put in place and family e-visits. There are other things we won't be able to cover in the 10 minutes because we want to focus on the how, which is, I think, the most unique element in this situation. Baycrest is home to a very sensitive population, very potentially socially isolated population. We have over 1,000 people in our campus that we need to serve, and it was very important for us to address the challenges that came forward. So let's start. So again, starting with our why, I'd say the first element is really when COVID hit, it was clear to leadership that we need to do something, even in the early stages. So dedicated teams were put together to understand the needs and try as much as possible to quickly respond. The teams anticipated that we'll have less face-to-face time with physicians, less options for staffing in the facility, and less option to move from place to place, restriction on family visits, and on group activities. We knew that we need to find innovative approaches to maintain essential services, and that definition of essential also has to be looked into, because social isolation definitely becomes essential, or is an essential issue. We had a clear need to act, but more importantly, we also had that willingness to make mistakes and fix them as we go, which is not very often trivial in an organization like us. The mission that we had as a TRIM group was really that was created in March, was to create this task force across Baycrest. We don't have a day-to-day team that deals with this. We needed to rapidly develop and deploy both telemedicine, e-visits, and other elements. It was structured as a team of teams with over 40 members across disciplines that came together into this interprofessional set of teams that dealt with the different issues that we had. So let me tell you quickly about some of the things that we did. Again, that's not the major focus. We do want to focus on the how we did them, but a bit of what was done at Baycrest, because I do think it is unique. So for telemedicine, we looked at this in the following way. So the challenge was how to allow physicians and caregivers to come and do inpatient care, which is not something we practice on a daily basis. Baycrest is lucky enough to have quite a few physicians and caregivers that work on campus on a daily basis. We had to now prepare for a scenario where they can't be on campus. How to develop a low-cost telemedicine card that we can deploy across campus, and how to assign teams and create workflows and support to actually make them happen. So that was the challenge. And again, I'm focusing on what here. So within a very short time, we deployed 30 telemedicine carts. We'll talk about them in a second. And through the last period of time, since April, we've had over 1,000 sessions of remote telemedicine. And those are just, or mostly, training sessions, because we're getting ready for a time we need them. But all our physicians managed to do this. They're all based on video, or almost all based on video conference, and that was very unique. On eVisit site, again, because people can't come in, we had to create platforms to allow families to interact with residents while there are limitations to the face-to-face, so make it virtual, make sure everybody has a landline or cell phone or iPad or something that can allow them to connect. And once again, just to give a brief snapshot, over the last few months through this e-visit program that was put in place, we've done thousands of e-visits to our clients. Some do them daily, some do them weekly. We try not to have a wait list, so all requests are being handled, and we'll get to the how. So really one quick slide before I hand it off to Kaylin about the how. So the technical side of the how is the T-cart. No magic there, it's just we sat together for a few days and defined what is needed in the telemedicine platform, and that included an iPad, Zoom, accounts, OTN as well, with infrastructure, but it's not about the technology. So Kaylin.
Thanks, thanks, Ron. So I think we might have made the assumption that everybody here has read Simon Sinek and The Golden Circle. If you haven't, I'm not going to take time reviewing it today, but go look at it. It may change your life. I'm just going to give a few examples though of how did we achieve this. And we really did have interprofessional collaboration at all different levels. At the beginning, even setting up the governance structure of the initiative, representation from every single clinical area, IT, ambulatory, security, privacy, and there really wasn't this hierarchy there. There was shared decision-making approaches. So starting from the beginning, that was a really big part of how we were able to achieve the why, the vision of what we were going to do. Can you skip to the next one, Ron? Thank you. So one of the other ways that we did it was the use of clinical liaisons. So during COVID-19, many of our services at Baycrest are ambulatory, and a lot of staff members were redeployed to work in other areas, as some of you guys have shared your experiences of being redeployed. So we created a role, clinical liaisons, that would facilitate the client-side telemedicine, client-side family e-visit, social engagement using a variety of different tools, also providing meal assistance. And this really truly was a interprofessional endeavor. The clinical liaisons, all of them have a clinical background, but there are neuropsychologists, social workers, dentists, dietitians, all filling this role and working very much in the same way with aspects of each individual role within them, supporting one another, teaching one another, learning from one another as well. So that was a great example of it. Even as we look to the training of the clinical liaisons and how we approached some of that, it was done in an interprofessional way. Not only with the clinical liaisons, but including feeding assistants, having medicine co-present with the technology side with the advanced practice nurses. Sorry, Ren, can you skip to the next slide? Oh, sorry, Ren, you skipped one of them beforehand. I apologize, sorry. The Virtual Care Resource Center was also an example of how the interprofessional nature of this team worked. It was a one-stop shop for everyone. Typically, we'll have supports available for nurses or supports available for physicians, but this was really an area where all staff could share, learn, develop protocols to help enable this care that was working. So how did we do it? I think that the shared decision making was a big piece of it. Also, we all had a unified philosophy here, the why. We'd established the why at the beginning. It was in order to be able to continue to provide excellent high quality care to our clients. And there, thank you, the clinical liaison. So summary, thank you. Brian,
we're asked to finish, so.
So am I up next? Can people hear me? Okay, well, I'm getting the signal that it's time to wrap up. My name is Ari Zaretsky. I'm the Vice President of Education here at Sunnybrook, and all I can say is, wow. I'm very impressed by the fact that you've been able to pull together this event during a time where I think a lot of people are distracted because of the COVID pandemic. There is still a lot of anxiety, and it takes a lot of effort to be able to, pull together this event at a time where you're also focused on the whole process of, clinical recovery, clinical care, all of those things. But I think that the reason why there's been such a strong registration and interest in this interprofessional collaboration showcase is because there's a hunger for education and a desire for a community of practice, especially at a time like this where people really want to pull together, they want to share ideas and be able to cope better. So kudos to all of you, but particularly I want to mention Elizabeth and the entire team that was involved in planning for this interprofessional collaboration showcase. The Interprofessional Collaboration Showcase has been going on at Sunnybrook for 11 years, but this is the first year that it went virtual. And again, I was a little bit dubious that you would have the kind of interest when you have a virtual kind of conference as opposed to a live conference. Many live conferences, as you know, have been canceled this year. And I have to tell Elizabeth that I'm a little bit jealous because our education conference, which is the other premier conference that occurs every year at Sunnybrook, did not have the same number of registrants. You had, at least for registration, 385 registrations for this conference. So again, I think that's really unbelievable, and 22 organizations. So again, the diversity, the interest is really outstanding. I just wanted to wrap up by noticing some of the important themes that were described at this IBC showcase. So obviously the first one is the importance of collaboration to create high-performing teams. And I should let you know that at Sunnybrook, we actually are focusing on high-performing teams as part of our strategic plan for the whole hospital. But we also have a new education strategic plan for 2020-2023, and the title is Meeting the Education Needs of a Post-COVID World. Meeting the education needs of a post-COVID world. And in there, we talk about team-based learning as one of the major strategic directions that will allow us to accomplish that. And as you know, our healthcare system, our education system are undergoing significant transformation. There's inflections in areas like telehealth and virtual learning that have been anticipated for the coming decade, but now are unfolding within the course of weeks, which I think is really outstanding. And all of us are adjusting to that new COVID world, living into this new COVID, and I would hope post-COVID world at some point. Another topic that was discussed or mentioned that was really emphasized was the importance of psychological safety. And this was discussed earlier on in the conference, the initial panel. Maria, Nazanin, and Tracy were talking about how important it is to have psychological safety and to make people feel welcome as part of a team, especially during a time when you're creating new teams, ad hoc teams, and people have to be nimble, they have to adjust, and they have to be flexible. And I would add, and this is part of our education strategic plan for Sunnybrook, that we need positive, culturally safe, and productive environments to support people at work so that they can reach their full potential. And I think all of you recognize that and have been giving examples of that throughout the day. The last thing I wanted to talk about is just an example, a personal example that I've observed over the last few months of amazing teamwork. And that was the teamwork at Sunnybrook that had to do with supporting our staff and our faculty and our learners with regards to well-being. So we had an ad hoc committee that was created that was interprofessional in nature. This was a combination of some psychiatrists that had expertise in trauma. We had social work, very involved, and we had our organizational development and leadership team also very involved. And that triumvirate, I think, was critically important in supporting our staff during some very difficult times. And what they did was that they actually measured the level of distress, and then they created tailored interventions to our different staff and different leaders in the hospital, as well as in different units, based on an understanding of the unique context of each part of the hospital. So this was an example, I think, of a very nimble and flexible approach. And what I was aware of from hearing about the implementation of this wellness strategy was that it was very important to provide psychological safety for frontline staff in being able to question and challenge the organization about issues of a strong concern, for example, related to safety. So if there were concerns about PPE, if there were concerns about the changes in how PPE was being deployed, in the approaches that IPNC was taking, in the way in which contact tracing was occurring when there was an outbreak, all of those things were very important for frontline staff to be able to talk about and to be able to question the organization in a way that was not disrespectful, but asking the organization to be as transparent as possible and pushing the organization to be more transparent and more transparent than they usually are, I think, in situations like this. And what I observed was that our organization responded in a healthy way to those challenges. And I think that that is what creates a team that can trust each other and can trust the organization and can work together during a very difficult time. So again, to me, that's an outstanding example of a high-performing team that was also an ad hoc team that was put together in a very quick way, but responded in a flexible way, in a thoughtful way, and in a way that allowed the organization to not only cope, but also thrive during this period of time. I guess I'm going to close off by just recognizing again all the work that you've done in putting together this amazing education event today, which has been, I know, live streamed on YouTube to many, many people. And I want to also thank our unsung heroes, Doug and Victoria from Sunnybrook Communications, that helped to make this happen together with Fatima DaCosta. And I'm going to close off and thank you all for participating. I hope you've learned a lot today. I hope you've been able to experience that community of practice. And I look forward to future conferences that hopefully will be in person, as well as the opportunity to disseminate all the things that we learn together virtually, so that we will have a new kind of post-COVID hybrid world where we use the new technologies that we've learned, but we also have the opportunity to interact together. So again, have a great day, and thanks again for participating today. Bye-bye.